with ISAR. Birthday wishes to our chairperson ICOG, Dr. Parag Biniwale. Hope you have a great day and a great year, sir, ahead.
Thank you. Thank you so much.
So we will have the virtual cake after the meeting. But now on to business. And thank you, Dr. Pratik Tambe, for this opportunity for coordinating day 3 of the FOGSI ICOG certificate course on infertility with ISAR. Today, we have amongst us a galaxy of dignitaries. And before we start, just a quick thank you to President FOGSI, Dr. Sunita Tandulwadkar, Chairperson ICOG Parag Biniwale, sir, Chairperson-elect ICOG Dr. Sheila Mane, Vice Chairperson ICOG Professor Ashok Kumar, Secretary General FOGSI Subarna Khadilkar Madam, and Secretary ICOG Dr. Sarita Bhalerao. So now without further ado, I would like to introduce you all, walk you through the day 3 program, which will have 2 sessions followed by a panel. Each session is consisting of 4 talks by 4 eminent speakers. To chair each session, we've got 4 chairpersons. And then there's a panel to be conducted, moderated by Dr. Pratik Tambe. So I think you can give an overview of yesterday's proceedings, Dr. Pratik.
So good evening, everybody, and welcome to the third day of the ICOG with ISAR infertility course, the certificate course, which we conceived of about a month ago. And we've all worked very hard, all the 3 conveners. Day 1, Dr. Fesi Lui, day 2, Dr. Seema Pandey, and day 3, myself. We've had a galaxy of eminent stalwarts in the field of infertility, both from ICOG as well as from ISAR, who have contributed to previous 2 days proceedings as well as today. And we're very thankful to the ICOG office bearers, Dr. Parag Biniwale and Dr. Sarita Bhalerao, Chairperson and Secretary of ICOG respectively, and Dr. Amit Pakki and Dr. Asha Bakshi, the President and Secretary of ISAR as well. Dr. Amit was there on the first day, and some of our dignitaries are in Japan. Thank you very much to Parag for joining, despite it being a busy day for him today, I'm very sure. Thank you very much to all the delegates who have been here for the first 2 days and done the post-test. There's one slide that we will have to read out, Dr. Monica, and that's regarding the instructions to the participants for the post-test. I would suggest to do that now before we start with the introduction of the chairpersons for the first session.
Sure, Dr. Pratik. Thanks for this. And I would like to inform all delegates who are attending this certificate course that attendance on all the 3 days course is compulsory. So today is day 3. You should have attended the previous 2 sessions also on 23rd and 24th. The Google link for MCQs, which you have to attempt, will be sent in the chat box. Those who have attended all the 3 days course and passed with 50% marks on each day, then only they will get a certificate from ICOG by email. The certificates will be sent within a month of finishing this course. Please note that this online course certificate is just an acknowledgement of attendance. Practice depends upon your skill and experience, which we are not certifying. So we do not endorse any skills of the attendees. The videos will be put up on ICOG website in due course of time. For course material and equipment details, you may communicate with the course coordinators. Thank you.
There is no pre-test as it was previously. From this year onward, we only have a post-test. I would request our chairperson, Dr. Parag Biniwale, to give us a few words of encouragement before we start the session. You can stop sharing, please.
Yeah, thank you, Pratik, and welcome to the third day of the certificate course on behalf of ICOG. I'm happy to see more than 100 people joining. The attendance for last 2 days was really good, over 400 delegates. And I must appreciate the efforts put in by all 3 conveners, three of my governing council members, Pratik, Seema, and Fesi. Well done. And of course, you have some excellent coordinators, including Monica, who are very, very sincere, and then when they take up a responsibility, it is fulfilled very well. My best wishes for the program and happy learning to the delegates. And the next course, of course, will be the last Wednesday, Thursday, Friday of May, and it will probably be on reproductive health. So we look forward to seeing you all again for that particular course. By the end of the session, we will Pratik will announce the exact dates. I'll message you, Pratik.
Thank you, sir. Thank you very much for being with us. Wish you a very happy birthday and wish you all the very best for your future journey in FOGSI as well. Thank you very much for being with us.
Yes,
We
thank you.
needed to have two of our dignitaries from ICOG who are going to address us during the inauguration. Dr. Sadhana Gupta is unfortunately traveling. She is our Vice Chair elect of ICOG. And Dr. Sarita Bhalera is busy in a general body meeting, so they will join us as and when possible. Without further ado, I would request Dr. Aarti, who is our Master of Ceremonies for today, to take the lead and introduce the chairpersons for the first. Can we have the chairpersons for the first session?
I would like to welcome and invite our chairperson for today's session. Can we have the slide? I think Dr. Sadhana Gupta ma'am is yet to join. She could not join for now. Can we have the next slide? I'll introduce ma'am when she joins us. Next, please.
Yeah, we have Dr. Harish Doshi with us.
I would like to invite Dr. Harish Doshi, sir. Sir is one of the very renowned persons who needs actually no introduction. Sir is a professor in HOD at Medical College Ahmedabad, Gujarat. He's been the teacher of teachers, and we've all learned a lot from Sir's books and his academic presentations. Sir has been a president of AOGS in 2003 and of SOGOG 2004, and also the organizing secretary for AISOG in the past. I welcome you, sir. Thank you for taking out your valuable time and being with us today. May we have the next slide, please? We have Dr. Padmaja Viramchandrani ma'am, who has done her MD from AIIMS New Delhi, and she comes from the city of Vijayawada. She has multiple awards to her accolade. She's been a member of FOGSI, IMA, PCOS Society of India, ISAR, and also the currently participant of AP chapter of ISAR, and has also been a member of other societies including ICOG, IFS, and ISOPA. She holds multiple positions, also including Rural Committee IMS Chairperson from 2025 to 2026. That is her current designation. She's also the South Zone Coordinator for the Quiz Committee of IFS and has held various positions. I welcome you, ma'am. Next slide, please. I would like to welcome and invite Professor Manisha Vajpayee, madam. She is the head of the Embryology and Research Department at Pacific Medical College, Udaipur. I welcome you, ma'am. Ma'am is also the managing committee member of ISAR. She's been the executive committee member of ACE and has also been the executive committee member of ISAR Rajasthan. She has multiple publications in peer-reviewed journals and PubMed-based journals. She has presented multiple papers at ESHRE and ESPRE conference. She also, as the embryology department, has done excellent work in the field of embryology research and infertility. I welcome you, ma'am. Thank you for being here with us. I would like to request one of the chairpersons to kindly introduce the speakers for our session 1 today. Dr. Manisha, could you please introduce Dr. G. Mohan, sir?
Thank you so much, Aarti, for your kind introduction. And at the outset, I must thank and congratulate Dr. Pratik Tambe, Dr. Monica ma'am, and Dr. Parag sir for organizing this such a wonderful learning platform for the newcomers or students. So it's my absolute privilege to introduce Dr. Reji Mohan. Dr. Reji Mohan is an associate professor at the Department of Reproductive Medicine and Surgery at Government Medical College, Thiruvananthapuram. Dr. AG is also working as a secretary currently at Trivandrum Ops Gynae Society. He is joint secretary of Indian Fertility Society Kerala chapter. He is member of Board of Surgical Super Specialist KUHS. He is chairperson of Reproductive Medicine Committee, Kerala Federation of Obs and Gynae. So over to you, sir. We are keen to hear you.
Thank you for those kind words. So can I share the screen?
Yes, please, sir. Go ahead.
Yeah. Is it visible? My audio is clear. Video is clear.
Yes, perfect. Please go full screen.
Thank you. First of all, let me pay my sincere thanks to the ICOG, Sunita Madam, Pratik Sir, Parag Sir, Ashok Sir, FOGSI, and all those senior members, respected Harish Sir, my chairpersons, Veena Madam, all those things, all those faculties over there. I'll be talking on patient selection for ART. So my outline will be like this, just by always by history we will start with. And what is ART, the indications for ART, when to refer the patient for IVF, and some take-home points. So history, always you should never forget history, because it started all with, we all are standing on the giants of seniors who made signs, symptoms, books, pictures, all those things. So we should never forget our seniors and great people. So we are always standing on their shoulders. Okay, so this is the first picture of sperm, that is animalcules, recognized by Anthony Leeuwenhoek. Then this is the great Carl Ernst von Bohr, who discovered human egg cell. Then Patrick Edwards and Steptoe. Again, first IVF birth in 1978, July 25th. Then you have to know about Gian Piero Palermo, who invented ICSI. And what to say, you have to see Professor Edwards with the Louis Brown and her baby, which proves that even an IVF baby can have a normal child and can rear a child and all those things. So what after getting the Nobel, after this, the Nobel laureate Robert Edwards has told is, the most important thing in life is having a child, and nothing is more special than a child. So with that introduction, you can see the world statistics. IVF is booming all over the world. Since 1978, after the first birth of IVF baby in Louis Brown, an estimated 10 million pregnancies are going on all around the world and still counting. Almost 1 to 3% of live births in US and UK is uh, basically from IVF. So globally, almost 2.5 lakhs IVF cycles are being million cycles have been done, and almost in India 2.5 lakhs. So if you take the statistics, in around 2027 and all, you will be doing around 5 to 6 lakhs IVF cycles a year. So that is, again, the future looks very bright, and I always and welcome all the future young practicing reproductive medicine specialists, those who are interested in infertility, to this topic. So first, let me tell about the terminologies. That is what is called MARIS, or the medically assisted reproduction. Reproduction brought about through the various interventions, procedures, surgeries, and technologies to treat different forms of fertility impairment and infertility. So this MAR, or the medical assisted reproduction, includes ovulation induction, ovarian stimulation, all those things. And ART, what is ART? ART includes all interventions that includes in vitro handling of both human oocytes and sperm or of embryos for the purpose of reproduction. So coming to the IVF proper, what is IVF? Again, IVF as a primary indication. So you shouldn't do any other procedures other than IVF in such cases. So the first absolute indication will be an azoospermia, where there will be difficulty of getting sperm outside the body. So you have to do some procedures to get the sperm, and that can be used only for IVF or ICSI. Severe male factor is another thing. Irreversible tubal damage. Your fallopian tube is damaged totally, so fertilization won't be happening. So IVF will be one modality to get them a baby. Then severe endometriosis, stage 4 endometriosis with blocked tubes and blocked pouch of Douglas, diminished ovarian reserve, and for fertility preservations. So you have to think of IVF other than the above mentioned conditions in severe ovulatory dysfunctions, endometriosis, unexplained infertility, as well as anovulation in a later stage, or when it is combined with some other indications. So what are the newer additions to this list? You can see gestational surrogacy, especially in MRKH, androgen insensitivity syndrome, for doing a PGT, same-sex couples, then prevention of mitochondrial disorders, potential correction of germline mutations, posthumous reproduction. All these are the newer additions to the list, which we have to go for an IVF. So when considering indication for IVF, you have to consider age, first thing, the ovarian reserve, and the indications in unexplained infertility, IUI, PCOS, tubal factor, and endometriosis. One by one, I will be covering. So you can see always as the age goes up, we are all worried about our phase, the transformation we are getting and all. But the female or the lady counterpart should be always be aware of the loss of ovarian reserve. So as you can see from this graph, this was published in 2004. You can see as the age advances, you can see the decline of the number of follicles. There is a slight decline in the follicles, as you can see in the slide. There is after the age of 35, and after 40, there is a rapid or a steep decline in the number of follicles in the ovary. So again, in this same thing, you can see once she reaches around 30, there is only 120,000 eggs, and by 37, it's only 25,000, and by menopause, it will be reduced to less than 1,000. So again, this is another beautiful graph which shows that the live birth and the pregnancy rate as the age advances is coming down, down, down. So after the age of 35, there is a steep decrease in the birth and live birth when compared to the maternal age. And you can see the FSH also goes up. When the FSH goes slowly up, again, your live birth per embryo transfer is also coming down. So there is a slow but steady decrease in fertility, which is observed between 30 to 35. But again, an accelerated decline is noted after the age of 35. So what happens in aged ovaries is there is reduced LH bioactivity, there is less functional LH receptors, there is impaired paracrine activities, reduced androgen secretions, which can result in an impaired oocyte quality, poor fertilization failure, reduced embryo grade, and increase in the pregnancy loss. So this study published in 2007 says that after the age of 40, the pregnancy and delivery rates are 13.9 and 9.1 at the age of 40. So when it reaches, it's around 0.7 and 2.8. So what you have to be sure is unrealistic expectations must be avoided if accurate data are provided regarding the delivery rates after the age of 40. So after the age of 40, don't give them unrealistic expectations. Always be realistic when you're counseling such patients. You show the graph and tell that these are the problems and these are the chances of your pregnancy. So this is another beautiful study published by Manish Bankar and Carlos Iglesias, which shows that ethnicity also has a role in the aging. So as this study shows that the ovarian reserve markers and the ovarian reserve, there was a 6-year difference between the Spanish woman and the Indian woman. So if an Indian woman is, a Spanish woman is at 40 with good fertility, that is corresponding to a 34-year-old Indian woman. So there is ethnic difference, and our fertility starts declining at an earlier age. That also to be kept in mind. So this is an NGS. NGS was done, and just see the rate of partial aneuploidy or aneuploidy. So you can see embryos with abnormalities increases with the age. As it goes more than 40 and all, you can see the contribution or the proportion of abnormal embryos. So it goes up, up, up as the age advances. So that tells that the importance of age. So after the age of 35, if the woman's age is less than 35, go for a conservative management. If it is between 35 to 38 years, go for an ovarian stimulation and go for an IUI if the tubes are patent and the male factor is normal. And after the age of 38 years, always think of an early IVF for a NICSI. So there will be societal changes. There will be social media selling that the dream of postponing motherhood, the grip of work is there. So always don't wait until the time is right, because you have to settle your career, you have to settle your house, you have to buy a house, car, and all those things. By that time, your ovarian reserve it get declined and it will be dried up, and you won't be able to become a mother. So always think responsibly. So coming to the next point, that is the ovarian reserve, age and FSH already told, and I will be dealing with IMH and antral follicle count. So antral follicle count is an indirect reflection of initially recruiting primordial follicles sensitive to FSH, and it also predicts the response to FSH stimulation. I don't have to tell how to measure this AFC and all. Usually it is performed with a more than 7.5 megahertz transvaginal probe. And the number of follicles between 2 to 9 is measured, and follicle number per ovary, if it is less than 1 to 3 and all, it is poor reserve. 4 to 24 is considered as normal, and more than 25 is considered as hyper-responsive or hyperstimulated. So just think, if both ovaries, again, if it is less than 4, poor reserve, then 9 to 19 is almost normal. More than 20, you have to think of hyperresponse or the polycystic ovarian type of ovaries. So again, this is a paper published by Sesh Kamal Sankara in 2011 in Human Reproduction. You can see as the number of oocytes retrieved comes down as the age increases, and and you can see that the live birth also decreases as you need a good number of eggs to get a good live birth. So at the age of younger age, you can see at the age of 18 to 34 and all, 18 to 34 and all, you need only few eggs to get it. You get a predicted live birth of 25%. If you get around 20 eggs in a retrieval, you get up to success rate of 40%. But look at the age more than 40 or 38 to 39. So if you get an egg of four numbers of egg, you see the predicted live birth is only 15%. If you get more eggs, that is say 20, the predicted live birth will be around 25. But it is very hard to get 20 eggs from a 39, 38 or a 39-year-old lady. So again, the live birth, this is another graph which shows the IVF outcome against AFC. So as the AFCs goes up, your live birth, the chance of live birth is increasing, especially when the age is less. Coming to AMH, AMH is a reliable biomarker of ovarian reserve. It is secreted by the primordial small and large antral follicle ranging from 2 to 7. You know the normal values. I'm not going into the details. So AMH is an independent predictor of live birth in women less than 35 years. But again, both this AMH and AFC, usually the reproductive medicine specialists, we usually combine the age, AMH and AFC and consider this AMH and AFC as the most sensitive and the reliable markers of the ovarian reserve. And it also tells about the FSH dose we required for ovarian stimulation. So again, what the practice committee of ASRM has told is you shouldn't be AMH should not be used to deny IVF. So you have to use your senses and tells that you have to correlate the findings. You have to correlate clinically, and then only tell that the AMH and the AFC is poor and there is a poor outcome for the pregnant for getting a baby. So the next situations that is you have to think of IVF. Coming to unexplained infertility. Unexplained infertility definition, I'm not going to the deep details. The options are expectant management, the ovarian stimulation by either clomiphene citrate, letrozole, or gonadotropin, or intrauterine insemination with or without ovarian stimulation, and finally the IVF or the ICSI. So you can see the two trials, that is the 2010 FAST trial and the 40 trial. And again, in older women, you can see that it's better to make it fast. Go for IVF as early as possible. So IVF is an effective and expensive method, but it has got its own drawbacks and all. You can, again, an expected pregnancy rate of 30.4% is there. Again, if the age of the woman is more than 35 with a prolonged duration of infertility and already undergone IVF or IUI for 3 to 4 cycles and all, definitely you have to go for IVF. So suppose if the woman's age is 33, less than marriage, the duration of pregnancy, infertility is less than 2 years, expectant management can be done. 3 to 6 cycles of COS can be done, and then consider IVF ICSI. If the woman's age is 33 years, more than 2 years, go for the COS with IUI for 3 to 6 cycles, and then think of IVF. Suppose if the age of the woman is 33 to 37, more than 1 year, again 3 cycles of IUI followed by IVF. But again, the think of that more than 37 years and all, at least minimum one cycle you can go for COS plus IUI, and definitely you have to switch on to IVF. So coming to the PCOS management algorithm, which is already you all know about the algorithm. What is the first line? What is the second line? IVF forms the third line. Once the first line, second line fails, you have to think of IVF. That is the third line of management in polycystic ovarian disorders. So this is the algorithm usually for PCOS. First, you go for the lifestyle modifications, then for oral ovulogins. If failed, add on gonadotropins, add on metformin, laparoscopic ovarian surgery in indicated cases. If all these fails, and in a particular the time, definitely you can go for an IVF. And whenever you're going for IVF, always think of antagonist protocol, agonist trigger, freeze all, and aim for an OHSS free clinic.
So we will need to wind up, please. We
Okay,
are already
okay,
2 minutes over time.
okay. Then I will go to the I think we started late, sir.
Yes, sir, but the timer shows you have 2 minutes over time.
Okay, so I will just wind up.
Thank you, sir.
So the last slide, I'll just. So to summarize, ovarian reserve assess and decide. The primary indications: don't wait for miracles. Unexplained infertility, be a systematic approach is enough. And ovulation, there is a control algorithm is there. Go for the stepwise matters. Tubal factors, evaluate and decide. And endometriosis, always think that it is a progressive disorder, and always early is the better. Thank you, sir. Thank you for the opportunity. Thank you very much.
Thank you very much, Dr. Regimon, sir. Brilliant presentation, lovely slides. Apologies, I had to cut you short there. We will have you again another day and we will give you much more time so that we have justice done for this wonderful presentation. Dr. Manisha,
Thank you,
any
sir.
closing
Thank you very
remarks? You are muted, ma'am. You will need to unmute.
Sorry, extremely sorry. It was a fantastic presentation, as you said, sir, with quite evident take-home messages. There are few things I would like to discuss, but time is not permitting. So probably, you, sir, you can take up in your panel discussion about the age at which we should shift for ART cycles.
Yeah, that was the entire focus of the presentation, and I think sir
So
took
I'll
home
be
that point very beautifully.
Yeah, so perfectly. Thank you so much, sir, for your such a comprehensive and lucid presentation with so much, so many clear take-home messages. Thank you so much. Wonderful having you with us.
We'll move to the next speaker, and I think Dr. Pragya has some issue with her laptop, so I've requested Dr. Asha Raman to be the next speaker. Can I request Dr. Harish Doshi, sir, to please introduce Dr. Asha?
My video will not be there, so my
No
voice you
worries,
can
sir.
hear.
That's fine, sir.
Well,
Yes, sir, we can hear you.
Dr. Asha Rao is a senior gynecologist. She's the director of Rao Hospital and Care Coimbatore, director for postdoctoral fellowship program in reproductive medicine and endocrinology, and is affiliated to Tamil Nadu Dr. MGR Medical University, Chennai. She is a past president of Coimbatore OBGYN Society, chairperson of Endometriosis Committee of FOGSI, organizing chairperson of many conferences, Endo Insight, UA FOGSI, IAG Star, and 8 National ISR Conference. Publications and research, she is editor for FOGSI Focus in Endometriosis in 2023, convener for FOGSI GCPR on endometriosis, co-editor for the book on endometriosis clinical management, and her special achievements are gold medal from President of India and from University in the final MBBS, delivered the first baby of Coimbatore way back in 1998, and first vitrification baby of
Dr.
Coimbatore in 2008. She'll be discussing the role of hysteroscopy in ART. Madam Asarao, please.
Thank you. Thank you so much, Dr. Harish Doshi, for those kind words. And at the outset, let me thank Dr. Parag Benewale, Dr. Pratik Tambe, and the team for having invited me here today to share my opinion on this very important topic. Let me just share my slides. Yeah, can you see it, Dr. Pratik?
Yes, ma'am, you can go full screen, please.
Yes.
So the picture that you see in the corner is from the UA FOGSI, which she did in 2019, 1,500 plus delegates. I was one of the few faculty who was there.
And I'm welcoming all of you again to UA FOGSI in Ooty now. That is June 3rd week, June 20th, 21st, 22nd, a romantic place. Please do come. All of you.
Look forward. Thank you.
It was great, UA FOGSI. Yes.
Thank you. Thank you for the compliments. We all thrive on compliments. And yeah, hysteroscopy prior to ART. All of us know that the first IVF baby will be shortly, I think she will be nearing 50 years. And so many developments have taken place in the field of ART. Millions of babies are born, yet endometrial receptivity remains an enigma in ART. Despite the progress, there is a real gap between the number of embryos transferred and the pregnancy rate, even using the top quality embryos and a normal uterine cavity. the implantation rate generally is around 60%. And why is it so? Embryo being considered normal, implantation failure may be often associated with uterine cavity abnormalities like endometrial polyps, submucous fibroids, adhesions, septa, sometimes cervical problems, cervical stenosis, and there is evidence to suggest that these may exert a negative impact on the conception through IVF FOGSI. And today, the best method of studying the uterine cavity is hysteroscopy, which is considered a gold standard for visualizing the uterine cavity and treating intrauterine pathologies at the same time. The other methods are hysterosalpingography, a low specificity, a high false negative and high false positive rate, sensitivity 79%, and specificity is 15 to 82%. TVS is really a non-invasive and reproducible technique. However, it is not that sensitive. Sensitivity 81%, but specificity is 100%. And if you do a little bit of, if you add a bit of saline with 3D ultrasound, it can really increase the accuracy of this technique. But all said and done today, hysteroscopy seems to be the only method for directly observing physiological and pathological changes in the endometrium that allows targeted biopsies at the same time and also treat at the same time. So see and treat. This is the big advantage of hysteroscopy. And small intrauterine adhesions, sessile polyps, endometritis, tiny fibroids, which may interfere with conception but not identified by ultrasound, will be seen clearly by hysteroscopy, and you can also treat it. And today, office hysteroscopy is coming in a big way. So if you can do a SIS, which causes some discomfort to the patient, why not to do a hysteroscopy also as an office procedure? So comparative accuracy, 3D is good for Mullerian anomalies, thick endometrium, thin endometrium, whereas intrauterine adhesions, fibroids, polyps, cervical stenosis, hypertrophy, etc. are studied better by hysteroscopy. A paper by Chung et al., who said that HST remains a very valuable screening modality, but hysteroscopy should be considered for definitive diagnosis and treatment, and these two are complementary to each other. And various intrauterine pathologies to be tackled by hysteroscopy prior to ART would be vaginal factor, cervical factor, polyps, fibroids, septum, intrauterine adhesions, adenomyosis, isthmocele, endometrial hyperplasia, endometritis, and retained products of conception sometimes. Uterine fibroids, all of us agree uniformly that submucous fibroids need to be removed because they interfere with the implantation. Fibroids distort the grade 0, grade 1 definitely should be removed. So fibroids distorting the uterine cavity need to be tackled. Intramural or grade 3 and 4, we have a controversy to tackle or not to tackle unless they are more than 4 centimeter. And there are any number of papers. This is a paper by Sandogan et al., where he showed that fibroids have a significant reduction in implantation rate and clinical pregnancy rate and increase in miscarriage rate. Cochrane database, 21% pregnant without hysteroscopic myomectomy, whereas 39% pregnant after myomectomy. And author's conclusion was that large benefit with hysteroscopic removal of submucous fibroid for improving the chance of clinical pregnancy. Uterine polyps, once again, according to Perez and Medina, they reported improved pregnancy rates by removal of endometrial polyps, even less than 1 centimeter. Jung et al. Once again agreed that even tiny polyps need to be removed. Clinical pregnancy rate 51% after polypectomy, whereas it is 25% in control groups. This is a meta-analysis, it's a systemic review. Once again, favors hysteroscopic polypectomy. And this is a paper by Chan et al., where they showed that with hysteroscopic polypectomy, the clinical pregnancy rate was 87% compared to 71% without hysteroscopic polypectomy prior to ART. So definitely hysteroscopic removal of myomas before ART will help in improving the pregnancy rates. AAGL also supports the same evidence. Uterine septum, sometimes there is a controversy. Length of the uterine septum does not correlate with the outcomes. Residual uterine septum of less than 1 centimeter does not impair reproductive function. And this meta-analysis, where they had 5 cohort studies and 22 case series. It's a paper published in ICOG in 2023. Results showed that patients with septate uterus and recurrent miscarriage, hysteroscopic septum resection was associated with increased live birth, resulting in very good postoperative live birth rate of 66% and reduced preterm birth rate. And the results were very clear in cases of primary infertility, whereas in cases of secondary infertility, the results were not that clear. So once again, there are small controversies. Again, does septum resection improve the reproductive outcome for women with septate uterus prior to ART ICSI? Again, there are, this particular paper says that it may not really help. And cervical problems, cervical stenosis, cervical adhesions, distortion of the cervical canal, and sometimes there's a hypertrophic tissue in the cervical canal, isthmocele. All these are very well studied by hysteroscopy. And this is what is called as Damodar calls it a curtain sign. There is a thick tissue on the anterior cervical wall, which interferes many times with the insertion of the catheter for embryo transfer. And when you resect it, it makes your transfer easy. And at times, the internal os is so tight that you may have to make a small nick on the cervical canal. There are patients where we have to do even 3 hysteroscopies because at one go, you may not like to release too much of cervix. So patients have sometimes conceived after 2 or 3 hysteroscopies. Intrauterine adhesions, especially, may not be picked up sometimes in spite of ultrasound, good ultrasound. Whereas with 3D, with the hysteroscopy, you can diagnose it and you can clear them at the same time. Depends on the various severity of the adhesions. So pregnancy rate can improve and the term pregnancy rate can also get better after hysteroscopic adhesiolysis. So we all agree that intrauterine pathology should be treated by hysteroscopy, see and treat, and it does increase the chance of pregnancy and live birth. So today, as we stand, why should we wait for multiple failures before we do a hysteroscopy prior to ART? Because it allows you to visualize the problem and also treat it at the same time. So isn't it more logical to do a routine hysteroscopy before first ART? This is the question today. And let us see what literature says. This is the trophy trial by L. Toki et al. 700 women, 350 allocated for outpatient hysteroscopy and 350 no hysteroscopy prior to ART, and ultrasound was negative, and they did not see any improvement in pregnancy rate. It was 29% in both the groups. Whereas the study by Pundir et al. In 2014, the very next year, showed that higher clinical pregnancy rates and live birth rates were seen in hysteroscopy group. This was a very impressive meta-analysis. And this is another study in 2019, uterine alterations in women undergoing routine hysteroscopy before IVF. And once again, these were the patients where the TVS was negative. They found high prevalence of unsuspected lesions, almost to the extent of 25%. Submucous myomas, intrauterine adhesions, etc. were diagnosed. So it's very important not to miss these findings by not doing a hysteroscopy prior to ART. And as the age went up, the probability of myomas also was going up. Whereas another paper shows that this is by Ben Abid et al., 2021. They had 171 women, 2 groups. The first group, hysteroscopy and then IVF. The second group, no hysteroscopy and IVF. The pregnancy rates in the first group with hysteroscopy prior to ART was 32%, whereas in the group 2 without hysteroscopy, it was about 21%. And live birth rates also were 23% with hysteroscopy and 19% without hysteroscopy. So they concluded that there is a marginal improvement in results, but it is not statistically significant. So when they concluded that when the transvaginal ultrasound and hysterosalpingogram did not show any anomalies, maybe the problems are minimal and they do not interfere with the pregnancy rates. So it is not worth doing hysteroscopy prior to ART. But many times a practitioner like me would say that a 10% increase in pregnancy rate is worth it for our regular patient, especially the Indian patient who are the bosses who pay for their bills. So this is all a generalized view where the NHS or the government is spending. Whereas in our patients, if we can get a higher pregnancy rate, our patients would do anything. In the cost in US is considered to be around $2,500 for hysteroscopy, whereas in India, perhaps you can do it within something like $200, 20,000 rupees. And if the patient is poor, I would reduce it, or vice versa, whatever it is. So our cost for hysteroscopy is much less, whereas their cost is much more. So for them, it has to be cost effective, whereas in India, the cost is variable. So many of our patients, if they can be benefited by 10 to 20%, it is worth it according to me. So in our center, around 2010, we were doing 2010 to 14, we were doing hysteroscopies for all prior to the first hysteroscopy, prior to the first ART. But today, we stopped doing it because we are doing very good ultrasound, 3D ultrasound. If necessary, we also do SIS. And we do hysteroscopy only after a first failure. Because at the time of egg collection, we do a trial transfer and minimal scratch, endobiopsy. So we started avoiding hysteroscopy and we were doing them only after failure of ART. So today looks like we should have a second look into our own thoughts. This is another paper, Fertility Enhancing Hysteroscopic Surgery, multicentric trial in 2023. In failed patients, when they did a hysteroscopy, out of 64 patients who had failed IVF earlier, 32 patients, 50% had a successful post-hysteroscopic pregnancy rate. So 50% conceived after the hysteroscopy, after the first failure. And especially the pregnancy rates were impressive with metroplasty, with the myomectomy, 63% compared to 37% with metroplasty. So they feel that it is beneficial to do a hysteroscopy definitely after the first failure. And this is another big meta-analysis, 5,038 women. They studied women before the first IVF and also after 1 or 2 failures. And live birth rates were significantly higher in women undergoing hysteroscopy compared to women who had no hysteroscopy prior to first ART. The clinical pregnancy rate also improved. Yes, I get So clinical pregnancy rate seems to be increased after hysteroscopy prior to ART. And once again, it also showed clearly that live birth rate in patients with a history of at least 1 failure, the hysteroscopy definitely improved the live birth rate. This is another paper in 2022. Is hysteroscopy prior to IVF associated with increased probability of live birth rate in patients with normal TBS after their first failure? Yes, the live birth rates were higher in study group. And hysteroscopy in unexplained infertility, pregnancy rates went up to 43% and live birth rate 38% in this patient. So this was beneficial. Quite a few were natural conceptions and some of them are ART conceptions. Maybe because of irrigating the uterine cavity, the anti-adhesive glycoproteins are removed, the debris is removed, and change in the cytokines, and distension of the myometrium, and good mapping of the cervical canal, endoscratch effect. All this may be helping to improve the pregnancy rates. And this is a Cochrane review by Bostils et al. 2018. They have done it for patients with suspected uterine cavity abnormalities. And they concluded that it is not ideal to do it for general population with infertility, do not do hysteroscopy, whereas performing diagnostic screening hysteroscopy before ART may boost the live birth rate and clinical pregnancy rate in women undergoing IVF. Again, it was supported by Kamath and Bostils in the next Cochrane review in 2019. This is Kamath's statistics that increase in live birth rate and also increase in clinical pregnancy rate. He said maybe further RCTs are required before he announces that it has to be done definitely. But he favored hysteroscopy prior to ART. Outpatient hysteroscopy impact on subsequent ART, systematic review and meta-analysis in patients with normal TBS and HSG. Once again, outpatient hysteroscopy prior to ART was beneficial, increased live birth rate, increased clinical pregnancy rate. So what do the guidelines say? ESHRE was not really supporting in 2000. Hysteroscopy should not be offered to infertile women who have normal TUVS finding. because it may not improve the outcome. NICE guidelines again said you do not do it routinely because you are not very sure of improving the results. And this was 2014. And 2015, ASRM said abnormalities of uterine anatomy or function are occasionally causes of infertility in women. They should be excluded by doing either HST, ultrasound, or FOGSI or hysteroscopy. So they came out a little better. Once again, HRA in 2022 for unexplained infertility, they say that hysteroscopy for the detection of possible correction of intrauterine abnormalities should not be done as routine if the routine imaging is not showing any. But I said, Indian patient who pays for their own bills, if we think that the results are going to be better, maybe we have to consider to conclude hysteroscopy is a valuable tool in evaluating the uterine cavity in infertile patients. If intrauterine pathology is suspected, hysteroscopy is recommended. Correction of intrauterine abnormalities has been shown to improve the IVF outcomes. However, the role of routine diagnostic hysteroscopy prior to ART remains controversial today. Further research is needed to establish its utility as a standard IVF procedure. And thank you all for a patient hearing. Thank you, Dr. Tambe.
Thank you, Dr. Asha Rao. Any closing remarks from Professor Harish Doshi? Thank you, ma'am, for this wonderful presentation. Harish, sir? I think we've lost him. Anyway, I think we should move ahead.
I'm there, sir. I am there.
Yes, sir. Yes,
okay. With all evidence, you have proved your topic, madam, that hysteroscopy, definitely when there is some pathology like fibroid polyp adhesion or anomalies, it is important and see and treat approach. For diagnostic hysteroscopy, although all guidelines are not favoring that routine, people are doing it routine in practice. And this has a psychological advantage also. The patient is told that your uterus is normal. Now we have seen from inside, the baby is going to remain there, implant and grow for 9 months. The house is good now, your house, baby's house, like that. But otherwise, scientifically, as you mentioned the last few slides, the evidence is not as on now, but may come soon that hysteroscopy is almost, because in a real sense, it is minimally invasive, right? Other minimally invasive is not that. This is really minimally invasive and not difficult to learn also. When you're doing ART, you must learn that, and people are doing it in and out. I think that is my comment.
Thank you very much, Dr. Harish Doshi, sir. Wishing you all the very best for your ICOG Vice Chair election next year. We hope to see you, of course.
No, I'm not going for
regularly before that.
Thank you, Dr. Doshi, for those lovely remarks. And my point is that if you can do a SIS in the outpatient, why not learn and do office hysteroscopy? And many small lesions can be tackled without making.
I think we are running out of time. We will need to move ahead, ma'am. We need to close
Thank you for this lovely opportunity.
Thank you, ma'am. Requesting Dr. Padmaja to introduce our next speaker, Dr. Pragya Mishra Chaudhary.
Good evening. It's a pleasure to introduce Dr. Pragya Mishra. She has a huge number of accolades, and the one thing I would like to tell about her is that she always gives very good logical sequence of events for us to follow whenever she gives us a talk. And having said that, she's the chairperson, Genetic Fetal Medicine Committee. She's been in the ICOG governing committee. She's been a very prominent part of Bihar chapter of ISAR, Patna OB-GYN Society, and she's got numerous awards. She's a very active member of ISPAT, and also of ISAPAP. Being a consultant infertility specialist at New Life Test Tube Baby Center, MGM Hospital Research Center at Patna. We welcome you, Dr. Pragya Mishra, for your talk.
Start sharing my screen.
Yes, ma'am.
Yes, please. We can't see it yet. You can share.
Yeah, I'm just taking.
So for those of you who logged in late, Dr. Pragya had some technical issues with her laptop, which are sorted now, which is why we had to take the next talk before hers.
Yes, Dr. Pragya, we are at the take home message. You will have to go home.
Yeah, I know.
Yeah.
You can just do from beginning, ma'am. Slideshow from beginning at the top.
Yeah, yeah. Actually, I'm trying to reduce the size of our so that on the right part. Yeah.
In the top ribbon, if you hit slideshow, you can do
I'm
from
doing
beginning.
that. Yeah, yeah. Just give me a second.
Yes, Dr. Pragna, we have you. You can move.
So at the outset, I would like to thank. I would like to thank ICOG and ISAR, especially Dr. Parag Viniwale, Dr. Ashok Kumar, Dr. Sarita Bhalerao, and Dr. Pratik Tambe, who has given this opportunity to me, and Dr. Padmaja for such a kind introduction, and Dr. Arti for the efforts, and also Nilima from ICOG office for her efforts. So when Dr. Pratik Tambe told me that I have to speak on this pre-IVF checklist and counseling, Dr. Padmaja, I'm clear, no? I mean,
Yes,
sound is
madam. Yes, Dr.
okay.
Pragna, we can
We
see
can
it
see
very
and
well.
hear you.
We can
Please
hear
go.
Yeah, yeah. Thank you so much. So then I really thought, that it's such a simple topic, and it's like it's a basic thing that he has asked me to speak on. But then I really feel that, this pre-IVF checklist and counseling is an integral part of, integral, or I would say the heart of any IVF cycle. And because of that, with good counseling and good pre-IVF checklist, we can avert a lot of problems, later on, which we can get into with the patients. So I think it's very, very important, this pre-IVF checklist and counseling. Now, this is just the IVF attrition pyramid, so you start from having many follicles in the ovaries, then visible small follicles prior to stimulation, large follicles at the end of stimulation, then retrieved eggs, mature eggs, fertilized eggs, then the blastocysts or the embryos, then genetically normal embryos, which end up into with clinical pregnancies. So any patient, when we have to counsel, you really have to tell them what is IVF in simple words, importance of pre-IVF counseling, and the goals of pre-IVF counseling are basically getting an informed consent, emotional preparation for the couple, and setting realistic expectations. Now, preparing patients for their IVF journey, writing the name, date, and the name of the institution, giving an overall overview of the IVF process, which means, you have to tell the patient in very simple words that you have to start with ovarian stimulation, egg retrieval, fertilization and embryo culture, embryo transfer, and luteal phase support. Now, before delving into the nitty-gritty of preparing for IVF implantation, it's essential to grasp the fundamental aspects of the IVF process. And, we have to tell patients in simple words that test tube IVF, which is test tube baby, it involves fertilizing an egg with the sperm outside the body, and the resulting embryo is then implanted back into the uterus. Now, while this may sound straightforward, the journey encompasses several stages, and each demanding careful consideration. Now, females play a pivotal role in the IVF process, and IVF preparation for females is integral to its success. Lifestyle modifications, including maintaining a healthy weight, adopting a balanced diet, and incorporating regular exercise, can significantly enhance fertility. And understanding the hormonal changes associated with IVF and managing stress through relaxation techniques are crucial aspects of female IVF preparation. Now, while females bear the physical burden of the IVF process, IVF preparation for males also plays a vital role in ensuring its success. Male fertility can be influenced by factors such as diet, exercise, and lifestyle choices. Incorporating foods rich in antioxidants, maintaining a healthy weight, and avoiding excessive heat exposure to the genital area are essential considerations for male IVF preparation. Now, the pre-IVF checklist, we have to do a thorough medical evaluation. So review the medical history of both partners when any medical problems in the past, like, hypertension, asthma, epilepsy, diabetes. Conduct a thorough physical examination. Ensure that any underlying medical conditions such as diabetes, hypertension, or thyroid disorders are well managed. Then assess the general history and fertility history, previous treatments and investigations, which is very important, because sometimes it's really lessens our job, so that, when she moves from, say, from you, she has come to you and seen other clinicians before, that, okay, these investigations, or, these things have been done, and what more you can add to give success to the couple. Then partners' medical and reproductive history. Then fertility testing. Now assess the ovarian reserve through tests like AMH, FSH, LH, ultrasound for antral follicle count, then infectious disease screening like HIV, hepatitis B, C, syphilis, check for male infertility issues through semen analysis and other relevant tests like DNA fragmentation tests. Now, psychological evaluation, that's also very, very important. Offer counseling, or refer patients to a counselor to assess their emotional readiness for IVF ICSI. Address any concerns or anxieties they may have about the procedure. Now, they would need emotional and psychological support at times. So, we need to talk to them about stress, anxiety, and coping strategies, counseling support services, importance of partner and family support. Then lifestyle modification, advise the patients to adopt a healthy lifestyle, including maintaining a balanced diet, regular exercise, and avoiding smoking and excessive alcohol consumption. Then practical sessions are given importance. It's and telling them that it's time to change your body. Discuss the importance of a healthy BMI for both partners. List of supplements recommended to be taken at least 6 months prior to conception are folic acid, iron, calcium, vitamin D, E, vitamin B6, B12, zinc, omega 3 fatty acids, iodine. Then medical, assess the medications both partners are currently taking and make necessary adjustments to those that may interfere with fertility or pregnancy. Now, immunization is very important. Ensure that both partners are up to date on immunizations, especially rubella and varicella, to prevent potential risks during pregnancy. Infection screening, screen for sexually transmitted infections and other infections that might affect fertility or pregnancy. Genetic testing, consider genetic testing for both partners to identify potential hereditary conditions that could be passed on to the offspring. Then screening is must in cases of male infertility with azoospermia or severe oligospermia. Then within lifestyle modification, the lifestyle factors which have to discuss are the impact of stress and ways to manage it, such as relaxation techniques or stress reduction strategies. Encourage both partners to avoid exposure to environmental toxins and chemicals that may negatively affect fertility. Now, financial consultation and planning are very, very important when we do IVF counseling. We need to provide a detailed breakdown of the costs associated with IVF ICSI, because, if you have made all the preparations and then you get to know that the couple is unable to afford the high costs of IVF. So we need to segment the cost of IVF and medications and explain to the patient, then give them package options or insurance coverage if applicable, then planning for multiple cycles also, regarding the costs of multiple cycles, then consent form, the most important part, when we talk about pre-IVF counseling. Ensure the patients understand and sign consent forms for IVF ICSI, including the risks and potential outcomes. Now, if needed, discuss the process of sperm retrieval with the male partner, whether through ejaculation, testicular sperm extraction, or other methods. So one thing, with consent forms, we overall have to take a consent, for IVF, but apart from that, for separately for oocyte retrieval, for embryo transfer, for frozen embryo transfer. Then if one is going for a donor IVF cycle, so we have to sign a separate consent. There are different consent forms, and each one of them has to be signed by the clinician, by the couple, and by a witness. Since ovarian stimulation also, we need to explain the process of ovarian stimulation in detail, the medications involved, and the associated monitoring, including ultrasounds and hormone level checks. Discuss the embryo transfer process, including the number of embryos to transfer and any specific preferences the patients may have. Encourage patients to establish a support network of family and friends who can provide emotional assistance during the IVF ICSI process. Follow-up appointments are very important, cannot be reiterated. We need to schedule follow-up appointments to monitor the progress of the treatment and adjust the plan as needed. So all these things have to be explained to the patient prior, because she may be residing in a far off place, and she may not really understand the implications that this IVF process will need regular visits to the clinic. So all these things have to be really made clear to the patient from beforehand. Then ethical and legal considerations, as I mentioned, that informed consent is very important, and documentation, which involves signing and signing by the whole team. Then embryo freezing and storage. Then third party reproduction when we are dealing with donor sperm, eggs, or surrogacy. So in those cases, especially ethical and legal considerations have to be explained thoroughly to the patients. Now, discuss legal and ethical issues, including the disposition of unused embryos and any related agreements. Now, coming to the success rates and prognosis, now it's very important for the clinician to explain to the couple that give them a practical success rate. We really need to explain to them that the success rate is not 100%, because if it fails, then they are going to eat your head out. So we really have to give them some feasible targets and feasible success rates. And also explain to them the factors affecting success, like the patient's age, the partner's age, ovarian reserve, cause for infertility. Then we also need to give them an individualized success estimation. I mean, the success rate of your clinic may be 40 to 50%, but in that particular patient, the success rate may be lower. So, it is important that, we do document an individualized success estimation for that patient. The number of cycles typically required, we, especially nowadays when people are going for segmental IVF, we need to tell them that, in the first cycle, we are going to retrieve the embryos, retrieve the oocytes, then create the embryos, freeze them, and perhaps after a month or two, we are going to do thaw embryo transfer. So all these things really need to be explained to the patients. Now, common myths and misconceptions also are very important, because patients really have some wrong myths, and they have misconceptions. Like they think that sometimes some women would come seeking to the IVF clinic because she has 2 or 3 female child, and she has come to you thinking that when you do IVF, you are giving she's going to have a male child. So all those myths and misconceptions really have to be removed, from the minds. And not only that, they have this thing. Some of them have a myth or misconception that the IVF babies are they are congenitally malformed, or they have genetic problems. So those things also, we really have to take them out of their minds, that these things are not correct. So clarify false beliefs about IVF success, pain, and the risks. Importance of evidence-based expectations, very important. encourage open communication, address the couple's doubts and concerns. Then counseling and support are the key. So it's important to tailor this checklist to the specific needs and circumstances of each patient, as infertility cases can vary significantly. Then clear communication, counseling, and support are essential throughout the IVF ICSI journey to help patients make informed decisions and achieve the best possible outcomes. Some take-home messages would be that at least 6 months before you advise a patient for IVF, we need to look into the following things like lifestyle correction regarding alcohol, too much of alcohol, smoking, sleep deprivation, then weight check. To need to tell the patient to get your to have exercise and diet, put these things in order. Then talk to them about the supplements like folic acid and calcium, preconception physical examination, genetic risk assessments. So find out if the baby will be at high risk for certain diseases. Then they have to be told that check with the doctor, the physician, what kind of medical treatment are you undergoing, or the drugs have to be modified before you embark upon the journey of IVF. Then ensure thyroid levels, vitamin D, and blood sugar are within range. So all these things really, so pre-IVF checklist is very, very important. And counseling, pre-IVF counseling is something we really have to spend. If you don't have, well, most clinics have a dedicated counselor, who counsels them. But if you don't, you really have to find time out from your busy schedule to counsel the patients on these aspects, because otherwise, if you don't do it later on, all these things can cause a lot of trouble to you, put you at a medical legal risk. So all these things have to be really explained to the patient, so that even I think I've finished on my time, so I'll stop here. So thank you so much for a patient listening. Thank you for your attention.
Thank you, Dr. Pragya. Can I request Dr. Padmaja to present closing remarks, and then we'll move to the next speaker?
Thank you, Dr. Pragya. So the doing an IVF is easier than talking to the person. We spend more time doing, we need to spend more time talking than doing at a pickup. I think that's what Dr. Pragya has been trying to tell us, that the youngsters should not be in a hurry to go into the OT and just pick up more number of oocytes. They should be talking to the couple realistically and telling them what to expect out of the whole journey. Because most of the people blame IVF doctors. They say the pregnancy hasn't come, but that is because we are not gods and we can't give a baby to them. So that we do deal with the matter that we are given with. Thank you very much, Pragya.
So as per the ICMR guidelines, each IVF center is required to have at least a part-time counselor.
Yes.
And in many clinics, it is the embryologist who does the job of that part-time counselor. So Manisha was asking me, what will I do in this session? So I said, this is a very important session where a lot of your expertise will also be required. Can I have the next speaker's CV, please, and request one of the chairpersons to go ahead and introduce our last speaker of the day for this session, Dr. Shweta, who's been patiently waiting for her turn to speak. Dr. Padmaja, you want to take that?
Yeah. Dr. Sweta Kolja is a life member of ISAR from 2012, and she's a gold medalist for the best student in MBBS, board certified reproductive specialist from Madhya Pradesh. She's conferred at such a young age. She's already got the Dronacharya Award of ISAR. She is worked in various positions, vice president in the Indore OB-GYN Society, executive member, MP, ISAR, and chairperson, Infertility Committee, AMPOGS. Welcome, Dr. Shweta, for your talk.
Thank you, ma'am, for the kind words. My presentation can be seen, right?
Yes, ma'am. Please go ahead.
So, today the topic given to me is adjuvants in assisted reproduction, and we'll cover it under certain headings. Due to paucity of time, I'll go a little fast. So basically, why there is a need of add-ons? We all know that in reproductive medicine, we all are striving for 100% results. But of course, none of us can offer 100%. So despite remarkable improvement in IVF technology, resulting pregnancy rate over last 4 decades, a significant proportion of infertile women couple, they still fail to conceive. Now, inability to achieve success, especially after repeated attempts, is devastating, and it is a clinical challenge to all of us. So, what are adjuvants? Adjuvants or add-ons are the agents, tools, or procedures that can be implemented alongside the core assisted reproduction techniques like IVF and ICSI, with the aim of improving fertility outcomes. Now, why this topic is so important today? Because according to HFEA, most recent national fertility patient survey shows that 3/4 of patients who had fertility treatment in the last 2 years had at least one or the other type of add-ons, and most of them are not adding to any beneficial effect. That is why a new person who is going into this field of reproduction should understand what is the evidence supporting which add-on, and as a doctor it is our responsibility to share with the patient the evidence and the pros and cons of treatment, and then it is up to the patient to whether go for it, opt for it or not. So these are the common adjuvants which are used. Adjuvants for ovarian response and oocytes like androgen, DHEA, growth hormone, metformin, antioxidant, artificial oocyte activation. Adjuvants for sperms are sperm DNA fragmentation tests, antioxidants, and IMSI and PIXI. I have hardly 10 minutes left. I can't go into detail of each one of them. So we'll just slightly touch upon the main parts. And in the last, I will conclude which are the important adjuncts. Adjuvants for endometrium implantation lie right from estrogen, aspirin, heparin, vasodilators, uterine relaxants, endometrial scratching, and corticosteroids, IV immunoglobulin, tumor necrosis factor alpha, intralipid infusion, GCSF, autologous PRP therapy, intrauterine HCG administration, and autologous peripheral blood mononuclear cells. So all this is available in the market, and different centers marketing themselves are having one of these agents and telling we are better than the rest. But what are the larger studies say that we should know? Adjuvants for embryos like time-lapse imaging, embryo glue, assisted hatching, elective freeze-all cycles, pre-implantation genetic screening, and PGTA, PGTM, PGTSR, and autologous endometrial co-cultures. And apart from there are some alternative therapies also which are used as adjuvants like acupuncture and yoga. So there is now a trend going for having a holistic center, because if we say only IVF, half of the patients run away. So people are now coming up with holistic center. You try acupuncture, you try yoga, you try nutraceuticals, and then when everything else fails, then you go for IVF. So let's discuss few of the common add-ons. Screening hysteroscopy, Dr. Asha Rao has taken a very nice lecture, and she has mentioned that ESHRE guidelines does not support hysteroscopy, screening hysteroscopy. But in a competitive world like today, it can be individualized according to case basis. As far as my personal thing is concerned, I do hysteroscopy before every embryo transfer. But the high quality evidence show no benefit to perform routine screening hysteroscopy in women undergoing IVF, and be it all women or those with tumor failures, but it may benefit a select group of women who have had one or more unsuccessful IVF attempts or history of difficult embryo transfer. So each person will have their different take on this, but it is such a minimally invasive thing which I don't think need much debate. According to the convenience and the patient and their desperate attempts, one can take a call. Now, this is an important test because it is offered at many clinics, endometrial receptivity test. And sometimes even after one failure, it is being offered, which is totally irrelevant, because these tests have been mainly applied to patients presented with recurrent implantation failure, which is properly defined as how many attempts with how many good embryos is being done. So first define the patient who needs it, and then whether it will be helpful for them or not. A large retrospective observational multicenter cohort study, including 5,000 plus ETs, with previously failed transfer, they could not demonstrate a better outcome after endometrial receptivity analysis. and personalized endometrium transfers. So both with autologous and donated oocytes, the live birth rate and cumulative live birth rate was significantly lower after receptivity testing. So to each its own, the evidence does not support ERA. In our practice, we don't propagate patient, but if they have multiple failures, if they Google and they come, we do offer them, telling them that it is still controversial. Then comes the next magic element of pre-implantation genetic testing for aneuploidy. So the current available data for PGTA using current methodology for genetic analysis indicate a limited improvement in live birth rate. We need to understand why it should increase the live birth rate. Like we have 4 embryos or 6 embryos, and if we do biopsy and study, we will get to know which is aneuploid, and so the euploid once we transfer. So it is basically a concept of enhancing your decreasing your time to pregnancy, because instead of 2 transfer you will do 1 transfer and the patient can be pregnant. But again, there is no guarantee of implantation. Plus you can decrease the miscarriage rate, but how does it increase the live birth rate? What is abnormal will be abnormal, isn't it? So these are various studies right from 2012 to 21. And you see the latest studies from 2018 to 21. Most of them have said the live birth rate has decreased or no difference. And miscarriage rate also they have said decrease. So the evidence does not suppose PGTA to increase the live birth rate. And even non-invasive PGT is currently not recommended for clinical routine use. So I have another 6 minutes left. So I'll just go through some theoretical things which are going on, like mitochondrial DNA load measurement. It is also not recommended in clinical use. They study, set of embryos and the ones which have the load like that, but it is still not used, so not going into details. Assisted hatching is another magic wand which people offer, that for frozen transfer, if they do assisted hatching, they will have a better pregnancy rate. But it also has, there are laser, mechanical, and other methods, chemical, but mostly laser is used, because these setups have laser for assisted hatching, plus they use it for PGT also. So they do offer also. But it has not shown to be beneficial in unselected or good prognosis patients, and no advantage was observed in women. Time-lapse imaging. Now, this also tells us about the morphokinetic division, like, when we study from embryo from 2pn to day 3, day 4, blast. So if we get this incubator has a time-lapse imaging, means it has a camera which will study the division of embryo. So one embryo that goes into blast can be like on day 3, 8 cell, and day 4 morula, and another can be still on day 3, 6 cell, and still it will form blast. So like this, we can screen the embryos which followed the physiological timeline, and that way they say we can get the better embryo selection, and there is better chance that they will be euploid and better chances to implant. But unfortunately, this also has not helped in increasing the live birth rate or time to pregnancy. So it is also not recommended as a tool to improve. Now, artificial oocyte activation. So I'll just go to the indication. It is recommended for complete activation failure, means there is no fertilization, or a very low fertilization rate of less than 30%, or a globozoospermia. Advanced methods of sperm evaluation like FOGSI and IMSI and MAX, they also are not being recommended, and microfluidics can be considered. DHEAs is again a controversial molecule, and the evidence does not support its use. Heparin, also Cochrane review validated the effect on pregnancy outcome without thrombophobia, and they also found no statistical significance. Antioxidants also, current evidence does not support the routine use of supplemental antioxidants for women undergoing IVF. So this is what the evidence says. Then seminal plasma, Cochrane review also validated the effect of seminal plasma, and there was no improvement in the clinical pregnancy rate. Platelet-rich plasma also, a lot of passion is going on for intra-ovarian and intrauterine insemination, but the evidence unfortunately does not support this also. Nitroglycerin is also a source of NO donor, and RCT did not find improvement in implantation rate, pregnancy rate. And IV immunoglobulins also, some people use it quite well. and but it is quite invasive, and there is no convincing evidence for the use and safety as an adjunct in women with recurrent implantation failure embarking on IVF. In fact, we get many patients who had their first pregnancy after taking IV immunoglobulin after recurrent pregnancy loss, but I mean, they just conceived spontaneously or with IVF without this therapy. So ultimately, it proves that it doesn't help. So I have 2 minutes left and some few more peripheral blood tests for immune parameters and uterine NK cell testing are not recommended. And embryo glue is the only thing which the ESHRE guidelines recommended. So current data indicates that addition of hyaluronic acid as an adherence compound in ET media and IVF increases live birth rate following fresh transfers without the significant effect on adverse outcomes, and higher multiple pregnancy rate was also observed. So this is the second last slide. I'm very well on time. So we conclude by screening hysteroscopy, low evidence, but you can individualize your patient and decide. DHEA, moderate evidence. So in our patients, we do give DHEA in the meanwhile they decide, or they are planning. So it is not a very invasive thing. Testosterone gel also we use in poor responder. There is moderate evidence. Growth hormones is little costly, so low evidence is there to support it also. Aspirin, heparin, also moderate evidence is there. Antioxidants for female partner and male partner. Quality of evidence is not available, but I think most of us, we do use it. Seminal plasma low. PRP, the evidence is not yet verified. Embryo glue, as I told you, it is little supporting. DNA sperm fragmentation, also limited evidence. And flushing of uterus, low evidence. Endometrial scratching, low. A few years back, it came very big. Duostem, also no data now, so we have stopped doing. Stem cell mobilization, no data. Steroids, no data. Freeze-all, low evidence. We do not follow freeze-all to increase the pregnancy rate. Time-lapse imaging, limited data. PGS, as I already told, and mitochondrial DNA and assisted hatching, as I already told. So to conclude, in the absence of any convincing evidence, any adjuvant therapy should be offered only after fully informed consent of the patient, based on up-to-date scientific information, and only if there is potential for cost-effective physiological and psychological benefit and minimum risk of harm. Clinicians should be fully aware of the best available current evidence, and patient must be informed about experimental nature of any adjuvant therapy being offered to them when there is no robust evidence of its safety or effectiveness. Thank you for patient hearing. Thank you.
Thank you very much, Dr. Shweta, for finishing dot on time. Closing remarks from Dr. Padmaja, and then I'll hand over to Arna.
Dr. Sweta, that was a very fast roundup. It was like a cricket commentary, tat, tat, tat. It went on very well. And I'm glad you brought out that we do a lot of things for our satisfaction and to have a sense of doing something. Maybe the placebo effect also works, but we should remember that it should not be a very costly placebo. So we should tell, this is what has evidence. This is what we are trying to do. And these are the options, and you can choose. And if you want, we will do it. We are doing it for a benefit of doubt. It is not that it went. And the problem is, for an individual patient, it might benefit her. So not, I mean, patients and clients are not mathematical models. So at one point of time, in one point of life, it might benefit her. So as long as it is not harming, is not too expensive, not adding on to the cost, because some of these medications are almost 100 rupees a day. So I think we should hold on to that. Thank you very much.
So ESHRE calls this, in inverted commas, shared decision making. And I think we need to incorporate this into our practices in India as well. Make the patient a willing participant in the decision making in her journey as far as reproductive outcomes are concerned. Dr. Arti, thank you very much for all your hard work. Would you like to thank the faculty for the first session?
Yeah, I would like to thank all the chairpersons who have contributed their time and valuable inputs. And I would also like to thank all the speakers for today for giving such beautiful and crisp insights and such practical take-home messages for today, and sticking to their time very honestly. I'd like to hand over to Dr. Monica
Thank you
Singh
very
to
much for all your hard work and work behind the scenes. Lovely to have you here with us. We have
Thank
Dr.
you.
Sadhana Gupta, our Vice Chair-elect of ICOG, who's logged in. I think she's traveling. If we can have her for a brief message. We missed her at the beginning of the program. If she is here, I would request her to please speak a few words. If she is unable to do so, then we will move on to the next session and Dr. Monica can do the honors and introduce the chairperson.
I think Sadhana.
I think she's probably in the flight, yeah.
Yes.
Hardik, go ahead.
So if Dr. Pratik allows, then after session 2 and before the panel discussion begins, probably Sadhana ma'am can log in that.
She's here, she's here.
Madam is here.
Fantastic. Thank you for coming, ma'am.
So good evening, Sadhana ma'am, and we welcome our ICOG Vice Chair-elect, Dr. Sadhana Gupta, to the program. And madam, we would like to have a few words of encouragement from you, please.
Thank you, Dr. Pratik. Thank you, Monica. It was wonderful program, and I really regret that I was not there at the initial, like when the program started. And I heartily congratulate Dr. Pratik, Dr. Monica, and all the conveners for this wonderful program. And I welcome all delegates. I see it is 200, around 250 people are there. And a wonderful talk we just had with the Shweta Kolja, because that is the something that is scientific, like evidence based, and clearing a lot of confusion. And it actually makes the assisted reproductive technology quite friendly financially, and the mental stress associated with it. So hearty congratulations, Shweta. I could listen and go through your slides. It was wonderful. And we look forward to the future session, further sessions. And I'm there here for to listen to talks around 30 minutes. So thank you, Pratik, and thank you, Monica.
Thank you very much, ma'am, for being with us. Thank you for your words of wisdom. We are running about 15 minutes late and we already have the speakers of the next session. Can I request Dr. Monica to introduce the chairpersons, please?
Thank you, Dr. Sadhana. Thank you, Dr. Pratik. After this, really informative session 1, where you learned about patient selection, early referral for ART, pre-cycle checklist, pre-ART hysteroscopy, and adjuvant therapies. We move on to session 2. We're going to learn about stimulation protocols, contemplate between day 3 and day 5 embryo transfers, and what are the recent advances in the embryology lab. For this session, which will run for about 1 hour, I invite our chairpersons, Dr. Charmila Ayavu ma'am, Dr. Archana Baser madam, Dr. Poonam Goyal madam, and Dr. Kanchan Murarka.
So I think Dr. Charmila is busy. We have Dr. Archana Baser ma'am with us. Can we have her introduction, please?
Yes. So I would love to introduce our chairperson for session 2, Dr. Archana Baser madam from Indore, Madhya Pradesh. Madam is the previous VP of FOGSI, as well as she's consulting OBGY specialist and director at Akash Hospital Indore. She holds the Guinness World Record for removing the largest uterine tumor. She also has, the post, she's held the post of organizing secretary of AICOG 2021 Indore, the fellow representative AICC RCOG West Zone, and the Imaging Science Committee Chair, CIFOG. We welcome you, Archana ma'am.
Thank you, Monica.
And I don't think Dr. Poonam Goyal ma'am is there.
No, Dr. Poonam is not here. We'll move on to the introduction of the first speaker. We'll introduce Kanchan later.
Okay. So, ma'am, Archana ma'am, could you please introduce our first speaker, Dr. Kaberi?
Dr. Kaberi ma'am.
Yeah, okay. Hi, good afternoon, everyone. Good afternoon from Salem. I'm here. And thank you, Dr. Aarti, for reminding me to join. It was a wonderful talk by Shweta. And now I am really pleased to invite my dear friend, Dr. Kaberi Banerjee. She is founder and medical director of Advanced Fertility and Gynecology Center, New Delhi, Gurgaon, and Noida. She is FRCOG London, UK, and I think she has several awards to her credit, and she has published more than 50 articles in national and international journal of repute and numerous original research work published in the field of ART. So I'm really happy to invite you, Kaveri. So the dais is yours to go on stimulation protocols in IVF and ICSI.
The most difficult talk of the entire 3 days has gone to Dr. Kaberi, but I don't think there's anybody else who can do more justice to it than her.
Thank you so much, Pratik, and thank you so much, Archana ma'am, for the kind introduction and the opportunity. And it's a lovely, course, and I'm very happy to present on this topic. So without any further ado, so the reason for ovulation induction needs to be very clear. We all know that a single follicle with a single egg can only do so much, and we need to have multiple follicles to improvise and increase our result. So in that scenario, the first IVF baby was a natural cycle, then came clomiphene citrate, and then gonadotrophins, the agonist cycle, the antagonist in the 2000s, and now it is the individualized and the OHSS free protocols that we are very proud to practice. So why do we need ovarian stimulation? We need it to recruit multiple eggs to improve our embryo selection and thereby increase pregnancy chances. And while we do that, we need to synchronize the follicle growth and prevent the premature LH surge. So these are the two problems of multiple ovarian stimulation, which various protocols handle. The most common protocol and the longest protocol after the natural cycle was the GnRH agonist protocol, in which it initially causes a flare-up of gonadotrophins, followed by the continuous usage leads to downregulation, enabling a synchronized follicle growth and preventing premature ovulation. This is one of the longest and has a lot of use in various scenarios, which we will come later. And followed by this in the 2000 came the antagonist protocol, in which there is a sudden block of the the LH surge and this rapid action of the LH suppression, and it does not take so long for the LH and FSH to suppress, and therefore the premature ovulation does not happen in a different mode of action, that is the antagonist cycle. One thing that we need to know in all of these is that there is luteal phase defect, though that is not what I'm covering. But in luteal, once you have aspirated multiple follicles and you have supraphysiological concentration of steroids, it is going to compromise your corpus luteum. And in all ovulation induction protocols in IVF FOGSI, which includes multiple stimulation, we need to give luteal phase support. Before we start, we already had lectures on checklist, but a quick run through what all checklists you need to have before you start your ovulation induction. You need to have your hormones in place, your thyroid's under control, your sugars under control, the HbA1c under control. You need to see whether the viral markers are in place. And also you need to give tips. Obviously, you cannot do it in a markedly overweight or an underweight patient. And if the couple or the man or the female is smoking or taking alcohol, we need to give some weeks to wean off that and then start. There is the role of adjuvants, and as has the various talks highlighted, there's a lot of controversy on whether we should give metformin, myoinositol, DHEA, CoQ10 in the dose of 300, testosterone gel to the male lycopene, carnitine, and CoQ10. Now, there is lack of evidence. The ASHRAE guidelines do mention that we need not give metformin or we need not give DHEA for women with PCO and POR for ovulation induction. However, it is the lack of evidence. And again, it is individualized practice. For me, I do give metformin, especially to obese PCO women, and I do give DHEA to reduced AMH women. And for the male factor, we try, especially in severe oligoasthenoteratozoospermia, we try to optimize. So before you jump to ovulation induction, just be sure your patient is in the optimized condition before you start. One of the most important caveats of starting ovulation induction is the fact that your estradiol levels have to be baseline. By baseline is ideally 50 nanograms per ml, but even up to 70 is considered. Many would just do an ultrasound on start day 1, day 2, whether it is after downregulation or whether it is simple day 1, day 2 scan. Your endometrial lining needs to be thin, that is 5 millimeter or less, and there should not be any functional follicle or cyst lying there. So if there is a cyst, you need to do your E2 levels. And if that is less than 70, you can utilize that cycle. If the level is coming 100, 110, you should not utilize that cycle. Now, there has also been a lot of controversy on timing. The agonist cycle had the advantage of continuing your agonist till you are ready to start stimulation. And this was more so in the days of batched IVF. In the West, it is important because they definitely don't like working on weekends. So they want to start stimulation only on a few days of the week. But in countries like us, in centers like ours, which is working all the time, max we will have only 1 day off in a week. We don't need to time so stringently. So the antagonist cycle was timed by the oral contraceptive pills. And the minimum time you need to give the pills is about 15 days. There have been studies that have come and said that the OCs in an antagonist cycle may reduce the overall live birth rate. But again, there has been certain controversy and discrepancies in various studies. The recent consensus, perhaps, is that progesterones and in POR, where you give estrogens, do not reduce the pregnancy outcome, but OCPs is a little bit on the plus minus, and those who want to time it can still use it. Now, a little bit about the gonadotrophins that we are using. Of course, there are various protocols of the oral plus gonadotrophins, and pure gonadotrophins. But because my talk is on IVF FOGSI and it needs gonadotrophins in most of the cases, we need to know that there are urinary and there are highly purified and there are recombinant. The urinary has about a 1:1 FSH to LH ratio, and the HMGs like the Menagon, Humog, the various drugs in the market, these are urinary products. Then you have the urinary FSH as well. Then recombinant, which is highly pure. There is a consistent approach. And then there is highly purified urinary, which again is better than urinary. But again, the consistency and batch-to-batch variation is not as good as recombinant. Now, one thing, all of you, when you start your stimulations and you take your drugs, you should be very clear about the cold chain. The cold chain needs to be maintained right from the manufacturer to the fridge to your patient. And just the cold injections that you get in your center does not ensure that the cold chain has been maintained right from the manufacturing. So it is only through time tested and testing, unfortunately, testing it on your patients, that you know that these drugs are well, the cold chain is maintained, and I can use these drugs. In the pure urinary, you will still see a lot of batch-to-batch variation. So the advantage of the urinary is that it is highly budget friendly, and the advantage of the recombinant is that it is the purity is very high and it is highly consistent. Of course, the disadvantage is the cost factor. So we need to kind of decide which way to go for which patients, for which we will come in a little while. So there's an armamentarium of drugs and injection from which you have to choose. Now, a few things which the new ones, the Pargoveris, which is recombinant FSH and LH, the cofalitropin alpha, which is the long-acting FSH, which these have come in the market with highly claimed efficacy and all that. But most of the studies, including the guidelines, have clearly mentioned no particular benefit or improved efficacy of one over the other. The only thing you need to keep in mind is in the pure urinary ones, the dose that you will use needs to be slightly higher than your titrated or your algorithm derived dose, because the purity is on the lower side. So how do you individualize the dose for each patient? It depends on multiple factors, namely age, AMH, antral follicle count, previous response, BMI, and associated condition. We know age and AMH and antral follicle. In the earlier days when we used to practice ovulation induction, this was very, very important because the trigger that was available was only HCG. And if you did not titrate your dose properly, you will end up with OHSs and its severe complications. But in today's world, with the antagonist protocol, with the agonist trigger, we are much safer that way. And yes, it's important to titrate, but it doesn't have to be, your patient will not get into huge trouble if you've slightly overdosed. Say 2 to 5 has gone to 300. Previous response is very, very important, and that will sometimes pick up hyporesponse or polymorphism. So, the age may be 32 and AMH may be good, but she did not respond well. You might want to add LH, you might want to give a dual trigger, and BMI. So, if say for a 32-year-old lean normal responder, you want to use 150 to 2 to 5, for the high BMI patient, your dose will definitely be higher and you may need longer stimulation. So these are the various things that you need to keep in mind. There have been various algorithms in which a high responder will take 150 IU and an expected low responder will take 300 IU, and in the extremes antagonist is preferred and the normal responder agonist. So these are various protocols that have been used. Then they have, like in the previous one, they have just used the AMH to decide on the protocol. In this, they have used age, AMH, and then they have drawn a line to the starting dose and decided which dose would be preferable. This is a paper by Sankara. And then there's another algorithm that can be done in which, again, BMI and your AMH, your antral follicle count, takes to the total points, and the total points then comes to the gonadotrophin usage. You can use all that. What we use in the clinic is basically age, AMH, BMI, antral follicle count, and previous response, and then titrate the dose. There have been the step up and the step down, but again, one thing you must know, that your starting dose has to be the critical determinant. Increasing it midway, especially for IVF FOGSI cycles, is not very optimal. You may not get enough synchronous follicles, you may not get enough M2s. And this similarly with a step down dose, but a step down is still slightly better. Step up. My time over now.
Yes, ma'am, you can take a minute or two.
Okay, so I would just like to say that when you optimize your total number of oocytes, the best number has been 15. Ultrasound is the best, optimal, inexpensive way to monitor. That has been proven by X-ray. You don't need estradiol or progesterone all the time to decide. So we do not do blood tests. So there's a whole lot of discussion on that. Cochrane also says that ultrasound monitoring is best. The trigger is HCG for most of the cases, except in hyper responders where you can give agonist trigger. These are the various factors, the duration. Another point before I close is always see if it's a short cycle, she may mature earlier. If it's a longer cycle, she may need longer days of stimulation. Dual trigger is given in certain instances, especially where there's recurrent immature oocytes and previous empty follicle syndrome. There are a whole lot of, protocols that we can go through. And the one last thing which I want to say before I finish is about empty follicle syndrome. And there are many hyporesponders for which your fourth, suppose there are 6 and you'd get 4 or 3 preantral follicles. In those cases, you can add LH, increase your dose, and give a dual trigger. So as you can see, it's a whole gamut, and I think I started late. I had only 12 minutes, and I don't think I can do justice to the topic in 12 minutes. But before I, stop, when there are no eggs coming, which happens, you've done a beautiful ovarian stimulation and there are no eggs, please check all your connections. Sometimes the follicle aspiration pressure is not good, but more important than that, always before you induce your patient, ask personally, especially when you're starting, when did you take your trigger? Did you take it at the right time? The best way to check it is sometimes doing a UPT for HCG and measuring LH for agonist, but there are true empty follicle syndromes as well, and they are listed here. So I'd just like to conclude here by saying that ovulation induction, it's a gamut where, the more you do, the better you get. And most important is safety. And don't forget that 1 odd patients can go into ovarian torsion. You have to keep your patients under follow-up. OHSs, you should have 0 OHSs in today's world. And that's about it for now. And thank you very much for the opportunity.
Thank you, Kaveri. Nice, crisp, very clear. And, like everyone, like even the beginner would understand the way you have explained. I think very, very excellent talk. And I think if there are any questions, we can take it in the chat box later, or you can please answer the questions in the chat box. You did finish in time, and I know you could have done more if you had have given you more time. But I think for the beginners and all, everybody, it was a good talk.
Thank you.
So,
thank you, Dr. Kaveri. Requesting Dr. Monica to introduce our next chairperson, Dr. Kanchan Murarka.
Yeah, Dr. Venugopal.
So,
can we introduce Dr. Kanchan Murarka and she will introduce Dr. Venugopal?
Yes, please.
So I'm very pleased to introduce Dr. Kanchan Murarka as our chairperson for the next talk. Dr. Kanchan Murarka is a senior gynecologist and IVF specialist attached to Institute of Human Reproduction. She is holding the post of General Secretary of Northeast ISAR Society. She is the Assistant General Secretary of Guwahati OBGY Society and the past treasurer of Northeast ISAR Society with more than 20 years of experience, several publications, a keen academician, and we are honored to have you, Kanchan. And we would like you to introduce our second speaker, Dr. Venugopal M. Hello, Kanchan.
Kanchan is muted. She has to unmute herself.
Kanchan, please unmute and introduce Dr. Venugopal.
Can you hear me?
We can hear you. Please go ahead.
Yeah, thank you. Thank you, ma'am, for the kind introduction. It's a honor to chair this session. So I'm pleased to introduce our speaker, Dr. Venugopal M. Sir is a consultant ART specialist in Birla IVF Fertility Center, Thrissur, and a member of FOGSI, Chair Andrology SIG IFS 2024. He's a secretary of KFOG from 2019 to 2023 and the president of Thrissur ONG Society 2018. So, sir, it's a pleasure to introduce you, and sir will be speaking on the day 3 versus day 5 embryo transfer. So, with great pleasure, I would like to invite sir to the desk.
So Venu and I go back a long way. He was a member of my endocrinology committee. We've collaborated on many programs, including the Helio Tomorrow CME series, which he had conceived of many years back. Over to you, Venu.
Thank you. As my slides visible, Pratik?
Yes, perfect. Go ahead.
Yeah. Good evening to all of you, respected seniors, and all those who are listening this evening. Thank you for the opportunity, and I'm thrilled to have the chance to speak on such an important topic because, when it comes to IVF, it's timing that makes all the difference. So, everyone sitting here, if you're involved in IVF or wishing to aspire to learn IVF, this always a debate of importance, like, when to transfer the embryos, most vital one, whether to transfer it early on the 3rd day or to wait till the 5th day. So, it's my job today to walk you through the science, through the strategy and the implications behind this choice, because there's some basic fundamentals you need to understand behind this particular selection, because every embryologist aspires to do the best for the patient and the outcome for the patient is nothing less than a pregnancy. See, this one slide, I think, is of biggest importance probably in the entire debate of day 3 to day 5. Because if you have a look at it, you find that there's fertilization taking place around, after fertilization here, day 1, day 2. It's only the embryo that coming into the uterus early blastocyst by day 5. This physiology, if it gets into your head, then you lose a lot of bias and regarding which stage of embryo transfer is the best, because see, it is physiologically premature to expose early stage embryos to uterine environment. That was the thought process, and then the embryo reaches the uterus equates to day 4 of an in vitro culture. So that's very important to understand. And it's very fascinating to know that actually the first human IVF was by transfer for blastocyst. And then they said the reasons that the fluid is stressful for cleavage stage embryo, adverse effects of stimulation are decreased, and large diameter. So large diameter, the blastocyst diameter is large, so it's less vulnerable to the contractility of the uterus. So, and also there's a lot of synchronization between the embryo and the endometrium. So all these reasons, in favor of blastocyst. But like pendulum kept on swinging, everybody knew that blastocyst is the best. But then, many people, many clinics still adopt the cleavage stage transfer because there are certain practical difficulties. Practical difficulties is difficult to culture day 3 embryo into a blast. I'll go through it step by step, So, those are some of the things, which brought this debate, and many centers still practicing day 3 transfers. When you do a day 5 transfer, what do you offer the patient? You offer the patient a better chance of going for a single embryo transfer. You offer the patient improved pregnancy rates per embryo transfer. And then if you plan to do procedures like pre-implantation genetic treatment or diagnosis, whatever, it's also very useful for that. So, it's a very big advantages, because ultimately what's the holy grail of IVF is that a mother gets a single euploid or a healthy embryo and a singleton baby. It's not about multiple, pregnancies. So, in terms of pregnancy rates, generally with blastocyst has good pregnancy rate, high pregnancy rates, higher implantation rates, and very good live birth rates. This is very important to understand. There are two major Cochrane database studies, one in 2016 and one in 2022 regarding this cleavage stage versus blastocyst, and all of them show that, in terms of clinical pregnancy rate, the blastocyst transfer is better. If you take for cumulative pregnancy rate following fresh and frozen transfer, again, the blastocyst transfer is better. And again, live birth rate outcomes, again, you see the diamond on the right side of the line. It shows that the blastocyst transfer is better. But to understand it, see, many of those charts, we don't understand it better. The summary of what is written here is very important. If you can take out some time to read what is given here, in terms of live birth rate after fresh embryo transfer, if 29% of women achieve live birth rate after a day 3 transfer, 32 to 42% would do so after a day 5 transfer. Isn't that good, significant difference? Yes. Same outcome that is shown in 2022 also. Similarly, clinical pregnancy rate per embryo transfer after fresh embryo transfer, if 36% of women achieve clinical pregnancy after day 3 transfer, 39 to 46% would do so after a fresh day 5 transfer. So you may see there's a difference there that is significant and very important when you're practicing reproductive medicine. These percentages, it means that out of 100 patients, you're getting 5 patients, 6 patients more down the line who are going to conceive. So this makes better sense. Then single embryo transfer. What's the holy grail of IVF? That you want your mother to have a singleton healthy pregnancy. So in terms of multiple pregnancy rates, again, even though there's a little bit more of monochorionic twinning in blastocyst, you find that generally you can able to transfer a single embryo transfer better when you use a blastocyst. Similarly, when you're doing pre-implantation genetic testing, see, pre-implantation genetic testing can be done on day 3 as well as on the blastocyst. But then it's always preferable and better to do the blastocyst for the simple reason that more cells are available for sampling, making it more robust, and the biopsy is less likely to harm the inner cell mass. So nowadays, almost everybody does blastocyst biopsies and not day 3 biopsies. And there again, you have to culture. So what is the difference? When you do a blastocyst biopsy, you have more cells, less mosaicism, relatively cheaper, and may improve live birth rate. See, these are very important fine points. You can't go into each of the studies in 15 minutes, but these are the points that you derive, like how the blastocyst scores over the cleavage. So, see, once again, I'll just round up all the points. Improved selection, you can select the better embryo, natural selection, better assessment, genetic testing, better clinical outcomes, that is implantation rates, reduce multiple pregnancy rates, better synchrony, lower miscarriage rates, and again freezing advantages. So all this adds up. What would you think that is not the blastocyst transfer the better or the best thing to do? But it's not without concerns of its own. We should also know the concerns when you're trying to culture an embryo for 5 days. Biggest concern is the cycle cancellation due to the non-formation of blast. See, there is a embryonic block after the cleavage stage. So all the cleavage stage embryos do not go on to form the blast. Also, you have fewer embryos for freezing. This is psychologically very important because patient will keep on asking you how many embryos you froze, how many times can I do IVF. This is very important. And then also there are other concerns like, altered sex ratio, perinatal outcomes. These are all important in terms of concerns. You should have, both sides of the coin, So see this unpredictable blastulation rates. Failure to transfer any embryo was high in the blastocyst transfer group. So, high means, see, again, here it is, if 1% of women have no embryos transferred in day 3 transfer, then 2 to 4% will have no embryos transferred in planned fresh day 5 transfer. That's the difference. So almost, even though it's not large, but it's important because, patients spending so much money, at the end of it, you cannot tell that, oh, sorry, I don't have any embryos to transfer. So what does the blastulation rate? This is important. The blast formation rate is very important. It varies from lab to lab. If you want to aspire to do only blastocyst transfer, your lab should be top quality and you should assess the blastocyst formation rates. That is, 50% of fertilized ova. If that's not the case, then it's a risk trying to aspire and say that, I'm going to. So the lab conditions are very, 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 very much important when you're trying to aspire to transfer blastocyst. And can you predict the lab conditions? Actually, you can't, because there are a lot of articles, they're crystal gazing as to how, how to increase the blastulation rates. So at sitting on day 3, what are the predictors that the embryo will go to day 5? That's very important. Embryo numbers, slow cleavage, intermittent, fast cleaving. So, you should have a very good team, very good embryologists and people who are sitting and monitoring these, constantly, and very good blastulation rates if you want to transfer blasts. Again, when you do blastocyst transfer, you will have reduced cryopreserved embryos. If you do day 3 transfer, you can tell the patient, I have stored the embryos in 3 straws, 4 straws. You have, you can do 3 tries, 4 times and all these things. But then that's less likely to happen when you're trying to do exclusive blastocyst transfers. Because the embryo freezing rate, both, I'm again mentioning these 2 studies, 2016, 2022 Cochrane database. So that's very important that if 60% of women have embryos on day 3 transfer, it's only 37 to 46 roughly would have after day 5 transfer. That difference has to be factored. Similarly, there's something called monozygotic twinning due to herniation of blastomeres due to culture-induced changes in the zona, which has high rate of perinatal complications. This is important to know, monozygotic twinning with blasts. Okay, though the general twins are not more with single blast transfer, but the monozygotic twinning is there. A small concern regarding that B for blast, B for boy. So a blastocyst transfer slightly alters the sex ratio and more in terms of boy. I don't know whether it's a concern, but definitely it's something to be kept in the mind. What about the perinatal risks? Rather than preterm birth, low weight, the blastocyst cultures, you have risks of imprinting disorders like Beckwith-Wiedemann syndrome, slightly large for gestational babies, sometimes preterm babies. So these sort of perinatal risks are also there with blast. So because the risks are there with blast, shall we abandon blast transfer and shall we transfer early? No, that's not the message to be given. That day 3 embryo transfer could also be done. it's not that the embryo, the human embryos have an unusual propensity to survive when even they are placed prematurely into the uterus. Okay, so you could do a day 3 transfer. Advantages, people say that the uterus is the best incubator, so natural environment, better to put it back, easy to select, you have high transfer rate, and reduce lab requirements. Like I said, you don't, sometimes you can get away with it with day 3 transfers. But the flip side, less natural selection. It's like running a race, at the end of a race, it's the best person who wins first. So the longer the race and the person who wins first is better. So in the day 3, you get less natural selection, lower implantation rates, and higher risk for multiple pregnancies because you're unsure of the embryo grading. The grading at the day 3 stage can't be so good as in the blast. So, you tendency to transfer more embryos. So who benefits from blast? You have to ultimately drive home some messages that are there in your mind. That it's a younger patient with a good ovarian reserve. Patients with high good quality numbers on day 3. So you don't have to do too much of a crystal gazing, like I said. Patients who want pre-implantation genetic testing. Patients, who are doing, you want a single embryo only for various reasons, that you last time you transferred twins and then, she got incompetence. All these people are the ones, or maybe uterine anomaly with less amount of space in the uterus. Yes. Then previous IVF failures at cleavage stage, despite having good embryo quality. Clinics with experienced embryology labs and good culture systems. This is very important. Your clinic is also important. Then frozen embryo transfers with better synchronization of endometrium and this possible. So these benefit from blast transfers. Who are the patients who benefit from day 3 transfers? The ones who will benefit from a day 3. See, the patients were less likely to form blast. Who is that? A patient with a low ovarian reserve, elderly patient with limited ovarian reserve, just few number of embryos, 4, less than 4, where, you're really doubtful whether you want to go for extended culture. Previous blastocyst arrest, like last time you tried it, it failed. Less experience or resources and fresh transfer cycles where early transfer may better match for endometrial receptivity. So, just on a concluding note, I made a line regarding the blast and the day 3. Transferring embryos at day 3 may provide the same benefits. Many of us would say, I'm getting good results with day 3, but then both have their specific advantages. You base your decision on patient characteristics, quality, lab capabilities, previous treatment history. So have personalized decision making rather than one size fits all. Thank you very much for a patient hearing. Thank you for the opportunity to the entire team.
Thank you, Dr. Venugopal. That was a wonderful express train where you showed us the advantages, disadvantages of each of day 3, day 5. And I particularly liked your second slide where you showed us the actual physiology. That is something, very basic things, first MBBS knowledge, but many of us who are into advanced practice, since many years we forget those basics. And there are questions also in the chat box. I would request you to take them. Can I request our chairpersons to introduce our next speaker, Dr. Nishad Chimote, since we are running late?
Yeah. Can I have the CV of Dr. Nishad? Dr. Nishad Chimote, welcome to ICOG Infertility master classes. I know Nishad is a very enthusiastic, energetic infertility specialist. He's MSc Biochem Fellowship of Indian College of Reproductive Medicine, Scientific Director and Chief Embryologist at Vanshadhara Center Private Limited. He has many, scientific commitments, and he has done ISAR Excellence Award 2023 and 21 publication in international and national journal, including fertility, sterility, human reproduction, contributed chapters in several textbooks on ART. So Nishad, over to you for your talk.
Right. Thank you, ma'am, for that wonderful introduction. I will move on to my talk immediately. I'm not sure if I will be able to finish in 15 minutes, but here we go. I believe you can see my slides.
Yes, sir, please. Yeah, your full screen. Go ahead.
Right. So we are talking about recent advancements in embryology lab. And I tell you one thing, I have given this talk every year, and the amount of studies I had to do in my master's, I am studying more every year because there are so many advancements, so many new technologies, so many new research work, and so many techniques are coming. And here we go. So why we need to do this? As an embryologist for a lab, for an IVF center, we know the history that it is evolving rapidly from the birth of Louis Brown to Kanapriya Agarwal, from development of ICSI in 92, then vitrification came in India by around 2007-8, then time-lapse imaging, which was earlier thought to be just some add-on. Now people are actually using, there are 50% centers in Europe which are using time-lapse machines. PGT has become a regular. Now AI-driven embryo selection has come into place. Automation has become a second nature of an embryologist now, and auditing, which we never used to do, has become 50% of our work. So we are changing, we are evolving. This is what is going on. So let us understand that these were the traditional role of just doing screening, checking fertilization, embryo culture, vitrification, lab management, troubleshooting. This is what we used to do in the lab. That is what we still do. But what are the recent things that are happening that we need to understand? So now the existing challenges is that we are doing batches, the number of cases has increased. Problem is you're not having enough embryologists in the lab. Because of that, there have been cases of burnout. Even the clinicians, they are getting burnout because there are so many cases that are going on. Also limited accessibility to, especially in remote areas, you're not getting liquid nitrogen, you're not getting dry gas. These are the small things which limit us from what we can achieve. It is affecting our efficiencies. And there have been papers published where UK and US, you can see the data here, where most of the problem is psychological, that you will be called on an emergency. Here you have to work more than 8 hours. You don't get paid for it. You can see in the graph, not going into detail of it. So what is automation doing for us? So basically, there have been a lot of things that have evolved, developed. I will be discussing it in the further slides. So there are softwares that we are looking forward. There are techniques like RoboHC. There are time lapse with AI, which are doing the embryo grading and so on and so forth. So many things are going on. So first of all, the softwares. So this is one of the software called Chloe, which actually taking care of all the details. 50% of our work after we do the pickup and the transfers and everything, this is what we do. We enter data, as much data as possible, or you can hire a data scientist or a junior embryologist who can fill in all the data. This will give you the idea for selection and planning everything. It's not only limited to that. The temperature, the humidity, the VOC, the HCHO, all these parameters are also entered and helps us to maintain and decide how the lab is performing, thereby reducing our stress of selection and making sure that lab is performing 100%. This is another software which is already in market. I have used it. It's amazing. It's called Violet. You can subscribe to it. It is expensive, but it's worth it. It actually predicts if the oocyte can give a viable blastocyst, what are the percentages? And some publications are also saying regarding this, it can also tell you just by looking at the picture of oocyte, the aneuploidy status. This is very interesting. And this is where most of the people are going ahead with that. In addition to that, this is called Magenta. In case, especially where we have a law of preserving only 7 oocytes from donors, selecting those 7 best oocytes, which will give you a viable blastocyst and for the better pregnancy rates. This software helps you to find out and assess and select those 7 for freezing. And this also follows and takes care of the whole working of the vitrification protocol. Then we got SID. This is very interesting. This is completely automated. A job of an embryologist to select a sperm. This actually does that on the flagellar movement of the sperm. I'll show you the video as we go ahead and select the sperm. It hits it with the laser and immobilizes. So it does both the jobs. Then we got automated robotic ICSI. It's already in the market, I believe, last year. And I think in ISAR or one of the conferences, we had one machine where I performed ICSI in Pune. I actually operated in Pune and the ICSI was done in Bangalore. So an Indian company is also coming up with such things. It's very interesting what is happening today. Yes, so this is very important. This is called electrowetting on dielectric or called EWAT, digital microfluidics. You must have heard about microfluidics for sperms. This is for embryo culture. You just put in the embryo, let it sit in the dish, which is under oil, and the media keeps on changing. There's a small dielectric current which pushes the embryo from one drop to another. Thereby, the pH osmolarity keeps on changing. In extended culture, you need not change the media, so you're not touching anything. This is absolutely amazing. The second advantage is it is also used for automated vitrification. So shifting from ES to VS, from second drop of VS, this is done by electrowetting, and it's absolutely amazing. This is how it is done. Spore cell, then it goes to morula, then blastocyst. It shifts from drop to drop. So this is the earlier one. Now they have evolved, and I'll show you what we have come to today. Yes, so obviously I'm not going into this part. I'll skip this one. So this machine has been there for ages. The only thing, it's too expensive, and we are still good at it. But for a very heavy lab where you're worried that the efficiency of an embryologist is not there, or you don't have a if you have got a freelancer coming to freezing and thawing, this machine does the work for you. Just put in the embryo or the blastocyst, it will do complete vitrification. You just need to store it. That's it. This is where we have gone. Also remember that the survival rate is pretty good. It's 92%, 94% in manual. Obviously, Gabby is giving the same. I'm not recommending any kind of machines, but yes, here we are today. Yes, now ultra rapid vitrification. I think Jorgen Lieberman is doing workshops all over the country. He's coming to India next month. We are doing a conference also. So the beautiful thing about this is instead of 15 minutes, you can do it in 3 minutes. This is amazing. Best part is that the survival rate is as good as what it was when we do it for 15 minutes. This reduces the cost, it reduces the time, and if you're doing batches or lots of transfers, it saves a lot of time. But especially if you see that even the pregnancy rates with these has actually improved. So this is something new. I'm also looking forward to this, and everybody is actually see the implantation rate here is 63% versus 57%. It's pretty interesting, and the data is quite robust. Yeah, so electronic witnessing, already we know there are so many machines, and this helps you to determine whether you are not goofing up in the lab and your husband is matched with their wife and vice versa. So there is no mix up, no movies will be made after this. Then obviously we know that Nobel Prize this year was won by AI. All is AI. This is for the first time. So why not move to AI? Why aren't we using it that much? Well, a matter of fact, we are. Now we know that most of the things that we use from phone, social media, OTT, everything, your phone, everything is here. Your phone has become your second hand. It's become your second mind. Everything is through Chat GPT or Google, and so many things that you are using. So where are we? Why are we not using it? Well, we are using it. It is now commercially available. And the only thing is it increasing our pregnancy rate? Well, no. But that is not the topic we are talking about today. We are just talking what are developments and how they are going to help us in the future. So yes, when it comes to the skill set, it's a repetitive job that you're shifting the embryos, you're doing ICSIs, you're doing freezing, you're thawing. So it becomes too much. Such jobs can be done by machines, and that is why we need them. And it will give you a proper result. There is no interpersonal mishaps, no differences. A machine in India will operate exactly like a machine in US or Europe. So coming down to this, I would like to show you this video. This is amazing. This is Aura, which is a lab in New Mexico by Jacques Cohen. It is called a $1 billion lab. This is the full automated lab. You can see that these are different units. The first unit is your sperm making or the sperm preparation, or the where you see prepare the semen sample. So here you can see that dishes are prepared. So dishes making is a continuous process. It's a repetitive job. The best part is it will maintain the pH. Here is most of the things that go wrong in the embryology lab. You take in lots of dishes, the pH or the osmolarity changes. The machine does not do that. So there is consistency, precise timing, and the oil is dispensed immediately. Can you see? This is the difference. A human being takes almost 10 times more in making a dish. It takes half a minute or 1 minute. Here it is doing it in seconds. In the same manner, now you can see that these dishes are also transported by these handlers into a rack. This rack goes into an incubator where they will be equilibrated. So this job is done very nicely. Then we got the andrology automated lab. Can you see the size of the andrology lab? The sample is taken, it is checked, it is done by CASA, then the sample is prepared. You can see that it is taken on a dish. These are special dishes, like the microfluidic dish that you can see that the semen sample is put in the media through those channels. Good sperms with less DA5, they flow through another channel and the sperms are selected. Now, I showed you about SID. This is how with the flagellar movement, it will select the sperms. These sperms are then selected and then we go and get ready for ICSI. So in between, you thought that screening is cannot be done. Well, this is follicular fluid. You can just put it in a dish. So this is done by optical CT, coherence tomology, the CT that we do. So this is optical. This is next level. It shows you 3D image. This is what it does and selects the cumulus, identifies it. And after identifying, it takes it into another drop where media is kept. This media will at least allow it to culture for 1 or 2 hours and also separate the COC from the oocyte, thereby denuding the oocyte. Even high rays is put. This is all automated. There is no embryologist, no hand involved. Then we've got the ICSI initiated. So here you can see how ICSI is working. The dishes from the incubator, the ICSI dish is prepared, the semen sample was taken, the oocyte was denuded. Now they're added to the ICSI dish, and now it will perform ICSI. Everything is automated. It is done very quickly. No time is taken. Now you can see the ICSI is done by software called Giro 2.0. Here it is going inside. The sperm is selected. This is what it is. See the sperm? And it is selected by SID, then it is hit by the laser. See the immobilized tail that brings about the capacitation, and corticosteroids are released so that it will form a fertilization membrane, thereby confirming that fertilization and oocyte activation will take place. Now ICSI is done within a few seconds. This is it. There is no man involved. Now the machine will shift the dish. It will reset for the next patient or the next dish. Now, how is this managed? Well, this is the behind the scene. This is called a C handler arm. This is what actually is shifting the dishes from the incubator into each station, whether it's the andrology station, whether the ICSI station, whether it is going for further freezing. So this is where it is going. Now the dishes are shifted from one station to another. This is the back end, and there is a camera, so you can observe what is happening. Everything is QR coded, RFID logged, so everything can be seen properly. Here we go. Now this will go further for either transfers, embryo culture, or freezing. So in just a small space, even smaller than our regular size embryology lab, you can see the difference. Now this is called Tomorrow. This is very interesting. This is from a company in New York, and they have a capacity of freezing lots and lots of oocytes, embryos, blastocysts. Also, they do a very huge data logging. So any dish cannot, any oocyte or any embryo cannot be mismatched. So matching is done very nicely.
We will need to wind up, sir. Apologies.
Yeah, I'm almost done. So you can see freezing is also done automatically. It is done quickly. This is the ES, which is going. The embryo, you can see, this is where it is loaded and it is frozen in liquid nitrogen at minus 196 degrees. So this is where we are at. So it's about time that we adapt, learn, and evolve. And I thank you for your patient listening.
Thank you very much, Dr. Nisha Chimote. Fantastic presentation, beautiful videos. You showed us truly how the AI lab of tomorrow, maybe 5 years, 10 years from now, will make people like you and I completely obsolete. Or maybe we'll be in one place monitoring 20 different centers all over the country.
We will be, sir, we will be evolving. I don't think, because there was a time where we used to make pipettes and medias. Now nobody knows how to make that. The only thing is that we'll be internal auditors. We'll be different kind of people. Our job profile will change. Embryologists will always be there.
Thank you. Thank you very much. Can we have closing remarks from the chairpersons, and then Monica can take over for the last session? Is Dr. Kanchan and Dr. Archana Base there?
Dr. Kanchan or Dr. Archana, could you comment if you're there?
If not, then we'll move ahead.
Yeah, I just wanted to comment in place of the chairperson that
Yes, of course.
Nishad just presented this talk in a different way of blueprint of an ideal IVF lab in the Synergy series. And I listened to it day before yesterday, and we were completely in awe. And we had a panel discussion about it, how to make this lab in India, which is very much possible, I think, after a decade. Thank you so much, Nishad. So,
Thank you, ma'am.
thank you. So with your permission, Dr. Prateek, can I move on to the panel discussion now?
Yes, please. We are already late. Let's go ahead. We have to wind up this panel in half an hour because we have a post-test as well.
Right. So we move on to the much awaited panel discussion at the end of two fantastic sessions today, wherein we have seen the entire IVF happening. But now Dr. Prateek Tambe, who is the moderator for this evening, will tell us how to maximize ART success. Dr. Prateek Tambe is very popular amongst all of us, and we know him very well as active in all the societies like ISAR Managing Committee, MSR Managing Committee, former founder governing council member of ICRM, that is the Indian College of Reproductive Medicine, and he is the very popular convener of the ICOG Reproductive Medicine course, and he's also our candidate, our favorite candidate for ICOG secretary. Wish you all the best, Dr. Prateek.
Thank you very much.
For the panel, we also have experts with us. We have Jem Kanan ma'am and Dr. Neelam Ori as experts. And our panelists are Dr. Jyoti Bali, Dr. Arun Madab Barua, Dr. Pragya Suryavanshi, Dr. Parminder Kaur Sethi, Dr. Sheetal Punjabi, and Dr. Sugandha Goyal.
So thank you very much to all our eminent faculty who have given us fantastic evidence-based talks today. We'll round it off with a simple and practical panel. May I request all the panelists to switch on their video and be prepared. If I can't see you, that means you're not there, and therefore the questions will not be directed towards you. So whenever I do a panel, I try to make it simple, case-based, practical, and usually we like to have a wide variety of cases addressing beginner infertility clinicians all the way up to advanced ART. So this is going to be completely case-based, brief, precise answers, especially if they're evidence-based, are always welcome. And if we have time at the end, maybe we'll do a rapid fire, but that doesn't seem to be very likely. I'd like to express my gratitude to Dr. Neelam Ori and Dr. Jayam Kannan for agreeing to be experts on the panel and being present. Thanks also to my friends, Dr. Jyoti Bali, who is a past secretary of Delhi ISAR, Dr. Pragya Suryavanshi, who is from the Chhattisgarh ISAR, Dr. Sheetal Punjabi from Ahmedabad, and Dr. Sugandha Goyal from Jodhpur. So we have representation from all over the country, no regional bias whatsoever. And we have people from both ISAR as well as ICOG, of course, as I remarked at the beginning of our entire program today. So we have a couple here who's married since 7 years, the very first case. They're trying to conceive since 6 years. She's previously had a right-sided tubal ectopic pregnancy that's about 3 years back, and unfortunately, she needed to have a salpingectomy done at that point of time. Subsequently, she is presented for secondary infertility. TSH, prolactin, AMH is normal. Somebody has done an HSG and it shows an irregular beaded left-sided tube. The right side tube, of course, has been knocked off because she had a salpingectomy. Partner semen analysis is normal, so the male partner is completely ruled out. This is a pure case of tubal infertility for our discussion. Jyoti, can I ask you, how would you go about counseling this couple? The vast majority of lay persons, when they have such a report, ट्यूब तो खुली है, एक ट्यूब नहीं है तो क्या हुआ, एक ट्यूब से प्रेगनेंसी हो सकती है. So how do we go about explaining the
I
situation?
think we need to explain to them that the ectopic happened 3 years ago and salpingectomy has been done. So there is a tubal disease and it will not be unilateral. It will be in both the tubes. And so more so to go and say that HSG shows beaded appearance. So of course, there is a disease there. And we talk about tuberculosis and we counsel them that there will be good chance enough if she's not conceived after the salpingectomy. So time is passing by. AMH, maybe whatever limits you've written within normal limits, but 36 is the age now. So there is no point trying. She's already tried for 3 years. So there is no way that she can conceive. If she's not conceived in 3 years, the way forward is ART.
So Sheetal, she comes to you and she says, Doctor, can you open that tube? The tube looks open, but if you feel that the tube is closed, why not open that tube?
Yeah, opening the tube it may be open, but it is a beaded tube. The functionality is not there. The cilia may be damaged inside. So this needs to be counseled and explained to her that this will not work because 3 years time is good enough time. Time is passing by and she needs to go on a treatment which is ART. There is no other way out.
Perfect. So now I think we've counseled this couple that one tube was already spoiled and that resulted in an ectopic. Usually, if there is PID, it's going to be bilateral. The other side tube has been proven to be beaded on HSG. We know that there are tubal factor issues here. Presumably, her uterus is okay, male partner is okay. So, with an IVF, she should conceive very quickly. And these are very rewarding patients if they finally agree to go in for ART at an early
Yes.
stage when the ovarian reserve is not compromised. So, Sheetal, here I wanted to ask you, if the couple says, Doctor, आप IUI क्यों नहीं करते हैं? How would you respond? You're muted, ma'am. You'll need to unmute, please.
I thank you, Pratik. Nice listening to all of you. See, for this couple, the counseling is very important. I would say that your tube is not functioning. When it is not functioning, it is of no use of going for IUI. So, we have to make sure that they understand that what is the function of the tube and why IUI will not give us a result in this particular case.
So many couples are under the impression that whatever ART we do, it's like magic, They don't understand the actual process of what is natural fertilization, what is artificial fertilization in the lab. And therefore, we need to sit down with them, explain that in IUI there is a natural fertilization for which there needs to be a patent tube. It needs to also be a functioning tube. And unfortunately, we don't have any tests for tubal function. We presume that if we see a patent tube, which is morphologically normal on laparoscopy or which is non-beaded, otherwise looks okay on HSG, that tube is functioning well, but there may be function issues as well. So here, once we've explained the nitty-gritties to them and they've understood this concept that maybe doing an IUI is pointless, doing a tubal surgery in this patient may also not yield much benefit because it's a beaded tube. What is the relevance of trying to perform a heroic functional or laparoscopic surgery to try and restore tubal function? Is there any relevance to that?
No.
Anyone can take that.
No,
Even
there will be no
if you do
relevance because,
laparoscopy.
sorry.
Yeah.
The problem is, can I?
Yeah, of course, ma'am.
Basically, the tube ectopic, if they are talking about the recanalization, the
Yes.
recanalization success rate, what we do practically, we need to explain the patient that in the cases of tubal ligation, where the tube is dissected in its central part, where both the diameters are same, in these cases, results are good. But now she is showing that this is ectopic pregnancy. That means that tube was diseased and it must have been ruptured in somewhere which is not, which must be an irregular part. That both the tubal diameters of the part must not be the same. Now this practical problem is going to happen in the second tube also. So practically we need to tell them the success rate is very variable in the tubal surgery. We cannot say that we'll be having good success rate, rather than they can opt for if the IVF, that would be better for them. So pros and cons we have to tell and then they will choose.
Very good. Dr. Sugandha, if you're there, I wanted to bring you into the discussion. Once this couple has opted for IVF, how would you proceed in this couple? We've covered all this in the preceding lectures, of course, so this will be just a quick brush up for the audience.
Yes, sir. Since everything is normal, her AMH is normal, uterus is normal, even semen parameters are normal. So the IVF antagonist protocol will be chosen. And the patient, we will start with a dose of 225. Her BMI was, I think, within normal limits.
Let's assume it's normal for the sake of discussion.
So we'll start with 225 and antagonist protocol, recombinant FSH.
Okay, why recombinant specifically? Doesn't that drive up the cost of the cycle?
I think it gives
we can
better.
use HMG as well. If the cost is a factor, one can use HMG.
Yes, HMG also.
Cochrane review doesn't say that recombinant will give us better or superior results in this.
True.
So
So
HMG
it
is
doesn't
good
really
enough.
matter which gonadotropin you use. Starting a good dose is important. And
Yes.
at the end of your stimulation, how many follicles or oocytes are you aiming for in this couple? That's a very important question, which we've not talked about so far.
Yeah. I think we must have minimum 7 to 8 good quality of oocytes.
Very good. Excellent. Excellent. So if you have 7 to 8 follicles and you get at least 80-90% success retrieval, then you will have at least 5 to 6 good quality top class grade A embryos, assuming your lab is working well, assuming that the husband's morphology is good, he doesn't have abnormal DFI or high number of morphologically abnormal sperm. That would give you a good chance of success in both the primary cycle as well as you would have some extra embryos left over to freeze. Now, very important question here is that many couples who have come to IVF centers have this myth in their minds, which is instilled maybe from lay persons or lay press, that once you go into an IVF center means you will come out with a baby only. 100% bachcha to hona hi hai. Dr. Sugandha, you practice in Jodhpur. It's
yes,
a metro city,
and
I know.
People from
but
rural
there must
areas,
be a, yes.
The people from rural areas, they come to us and they expect that IVF means 100% success.
Exactly.
And I tell them this only ki if there is 100% success, then my center would be famous in the entire world. So there is the success rate is limited. It depends upon the embryologist and the lab parameters. So mostly the success lies between 40 to 50%. And they say that few centers claim 80%, 90%. They say we guarantee hai kya? So I say this is all, I think, fraud. If anyone says we give 100% guarantee, there is no word as such guarantee. We can do our best with best injections, lab parameters, embryologist, and good clinician.
So as we were discussing earlier in the pre-cycle checklists and counseling, it's very important for us to sit down with the couple, manage their expectations, ensure that they are fully informed, aware of what is the couple and disease-specific success rate before we proceed ahead. Having said that, Jyoti, would you expect a good success rate in this couple? Because otherwise there's only a male tubal factor.
AMH being intact, I will definitely expect a very good result with good lab and everything there. With expertise there, I think I would expect a very good result in this particular case because the only factor is tubal factor.
So these are like spot diagnoses, and
spot
these are the
diagnosis,
ones
yeah.
which
Easy
give you
cakewalk.
very quick, very rewarding results.
Very rewarding
Sometimes
results
you
with
don't
these
even need
cases.
to resort to the frozen embryos in the fresh cycle itself. You
Yes.
get a good result. I'd invite some comments. Yes, Dr. Sheetal.
Yeah, looking at this beaded tube, I would definitely love to check for the endometrial tuberculosis as well.
Yeah, very good.
Okay.
Yeah.
Okay. Very good. I was just coming to Dr. Neelam Mori and Dr. Jayam Kannan because that is what I wanted their expert opinions on. Because everything looks fine, but then we need to ensure that all other factors are
Problem
ruled
will
out
only
before
be
we
if the
go.
lining is not great, then yes, this will come up. But maybe the factor was only limited to the tube, then we will have a cakewalk on this. But if the uterus lining is not coming up, then of course you'll have to freeze the embryos, tuberculosis, and sometimes even testing it doesn't give clinical judgment has to be on the lining. If one or two cycles the lining is not coming up, then of course you have to suspect and give AKT and then plan transfer.
This only thing I wanted to add, and coming, if one tube is, the self-injectomy has been done due to ectopic, another tube is beaded. So first thing that comes to my mind, especially in this part of India, that is tuberculosis. So we'll check whether there's fluid in the endometrium, maybe fluid in the tube also. And then I will certainly like to give her ATT for 6 months in her case, because other tube is also beaded. And then I would like to start IVF.
And
so rule out any active infection?
Yes, of course, I will check if endometrium is very nice, there's no problem in tube, then I can think of not giving ATT, but I will very critically see for the signs or symptoms or clinical signs of tuberculosis.
So thorough evaluation of all factors and then
Screening
ensure that it
hysteroscopy.
was. Dr. Shikal, yes?
Yeah, the way we were discussing about screening hysteroscopy, so few of such patients may probably are the right candidate for screening hysteroscopy and even endometrial biopsy or TB gene testing.
Yes.
Because
Very
then,
good.
yeah, otherwise we may end up not getting the embryo implantation. So this is very important to check endometrial receptivity in these patients.
Excellent point. So I think we've covered a lot of ground in the first case. We talked about tubal factor infertility. We also talked about how to counsel couples, how to manage their expectations, how to give them realistic ideas about success rates. We'll go on to the
Pratik,
next. Yes, ma'am.
I think one point which has to be taken up is
Yes, ma'am.
even if you do an ART, there
Yes,
can
ma'am.
be 1 in 1,000 chance of a recurrent ectopic.
Yes.
Your
Oh, yes.
embryo can be taken into the fallopian tube.
Yes.
So
Yes,
in this type
heterotopic
of
pregnancy
case,
and
yeah, I can even if you are putting double embryos, you can get heterotopic also. So probably if
document.
after embryo transfer, one embryo transfer, if the patient has not conceived, I would have consulted her for tubal clipping.
Yeah.
As such, antituberculous care in a silent infection does not improve the stroma. It does not improve pregnancy rates.
Only if there is
Whereas,
an active infection.
yeah, if there is an active infection, all your tuberculin tests would have shown it. In which case, we are very clear. In the absence of an active infection, AKT is very difficult to give, especially in the present scenario of every case of AKT3 or 4 is to be reported to the
Has
government.
to be reported. That's true.
Yeah, so it is not that easy to give AKT. And if there is one failure, consider a laparoscopic clipping of that tube so that you will be able to maintain the 35% chance of success in these people.
Thank you,
37
ma'am.
years, 35 chance of success. Thank you.
Thank you very much for those expert insights from both of our experts. We'll go to the next case because we have just 15 minutes left, and this is a
Yes.
very important case. In fact, I wanted this to be the only case for discussion because all of our audience is not primarily IVF specialists. It's general OBGYNs, common FOGSians, people who practice basic infertility, and maybe trainees, people who are just starting out in ART. So this is a lady who has a BMI of 34. She's trying since many years. She has PCOS and she's going to undergo IVF. So can we discuss in detail, step by step, how we approach IVF stimulation in a patient who is a known case of PCOS? She's an obese classic PCO with a BMI of 34 and she's already undergone several cycles of ovulation induction, but she's not conceived. Dr. Sugandha, you want to start?
So first, the BMI of this patient is 34. So lifestyle management should be the baseline. But lifestyle management should be along with IVF treatment. We should not waste time in if we say to patient that for 6 months you do lifestyle management and then come to me after your BMI is 25 or 30. So no, it should be along, and the add-ons depending upon the report of FSH, the hormonal reports, the add-ons if metformin is required or not, and the patient should definitely go for IVF antagonist cycle.
Okay,
And
well,
the
I'll
patient
stop you
should
there. I'll stop you there because we'll have to have a few answers for the other panelists as well. I'm going to ask Dr. Pragya. Lifestyle modification is all very well, but when it comes to starting add-ons, what
I
are
think
your add-ons of choice or insulin
I
sensitizers of
need to
choice?
see here. I need to see her insulin resistance
Yes,
and her because she is on the PCO side, obese along
she's
with
BMI of 34, so it is
yeah.
established that she has
So
insulin
maximum,
resistance.
if metformin we can add on her,
Hmm.
and depending upon her
So how
this
much metformin do you start? When do you start? How long do you continue?
baseline for the normal body weight, I start with 500, but this patient, depending upon her, if her sugars are normal, then we can start with 1,000 because if sugars are normal, but insulin
Yes.
resistance is present. So these things are, we have to balance the things. The sugars are normal, insulin resistance is high, these opposite things can happen. So along with this, you have already started the diet management and exercise. So
So if
by
I can ask you, what
hormone,
is the relevance of starting metformin? Why do we need to start
so
metformin in
it
this?
increases the sensitivity for the hormone. The ovarian
Okay,
stroma become the sensitive, where the receptors become sensitive for the hormones. Once
all right.
you have taken in this, and you will start with anti protocol, whatever the FSH you will give.
So I'll stop you there,
Those
and I'm going to go to Sheetal. Any other advantages of starting insulin sensitizers? You're muted, ma'am. You'll need to unmute, please.
Sorry. Yeah. So like after the conception, this metformin will help her in normal healthy pregnancy as well. Right.
I'm
And
not really sure. That is still controversial today because some guidelines say you stop it after the patient gets pregnant. But during the IVF cycle, does metformin help to reduce the chances of ovarian hyperstimulation, you think? And that's a very important indication for starting it pre-cycle, at least 1 month, 2 months in advance.
double benefit.
Yes.
It's having double benefit.
It has a definite benefit. Yeah.
So, Jyoti, in your experience, all these new medications which have come, myoinositol, dechiroinositol, berberine, a lot of insulin sensitizers are now available in the Indian market because it's like a lawless wild west. We don't necessarily mandatorily have to follow SHA or ASRM guidelines. And in India, whatever is marketed, every MR will come to you and tell you this is the best insulin sensitizer available.
True.
So what is your experience with the other insulin sensitizers which are available in
Only
others?
thing is the side effects of GI side effects of metformin. Some patients are unable to tolerate. So maybe there I have used, but metformin has better results. That definitely
Metformin is
performs
much more
better.
preferable.
And along with metformin, I would add that I always look at the B12 levels and supplement B12 in these patients. And GI side effects are the ones, so gradually from 500 to 1000, and maximum dose is 1500 milligram per day. So it has to go, you can't start with 1000. One has to start with 500 and then maybe after a week, 10 days, make it 1000. And if the patient is obese with this BMI, of course, maximum dose is 1500.
Perfect. Now I'm going to come back to you, Dr. Sugandha, and I'm going to ask you a very important question for which there is no correct answer. In fact, I myself don't know the answer. Should we give OC pills pre-treatment before you start the treatment cycle in a patient with obese classic PCO?
Sir, recent guideline says that OC pills should not be given. Any
Okay, and what
pre-treatment
is the reason for that?
because although the earlier guidelines used to say that all the follicles they come at the same stage and hormones are regulated, but it can cause more suppression, and the number of follicles which we obtain during retrieval may be less.
Okay. Dr.
And
Sheetal has raised her hand. Dr. Sheetal, please unmute.
See, the only advantage which was mentioned earlier in the literature was that, like, the LH level has been very high throughout. So maybe
Okay.
this particular group of the patients, sorry for this, the particular group of the patient wherein like LH has been chronically high, then only probably the use of OC pills in the case of a very obese PCO may help. Otherwise, it's of no use and
Okay.
not to waste the time actually for.
But Dr. Pragya does only batch IVF. She doesn't do ongoing IVF. So she gives OC pills to all her patients. Right, Dr.
No,
Pragya?
sir, no, sir, I don't give. I literally you do not use OCP.
So
And
you
I
don't like OC
don't
pills
touch
at
IVF.
all. You don't like OC pills for down
No,
regulation at all
no,
and
sir,
scheduling.
no, sir. I have
Jyoti, what
stopped
about
giving.
you?
I have used it from 2010 to 2013 and it gives fantastic results with batch IVF. When I started in 2010, there is
Exactly
absolutely good synchronization, good batching, and of course the cancellation rates are less. And now also if
So if it
required,
works so
at
well,
least
why
one
don't we use
cycle.
it now? If it works so well
Yeah,
and we have so much experience with it, we are so happy with it,
I have been
and
using it.
patients are also happy with it, why are we not using it anymore?
I am using it for these patients. One cycle,
So the
yes, I've
theory
been
is,
giving it.
the theory
I'm
is
not
that
using.
maybe you might require higher consumption of
Dosage.
FSH. You might require more ampules of FSH, longer duration of stimulation. There is a chance that you may have a larger cohort of follicles coming up. All these are stated as the disadvantages of using OC pills because it leads to profound suppression. There's also somewhere in literature mentioned that this profound suppression of the pituitary for maybe 1 or 2 cycles by the OC pills that we give may result in empty follicle syndrome later on when we give our GnRH agonist trigger. I don't know to what extent that is true. But that is why some of the modern guidelines now don't
not come
recommend
across
efficacy.
that. Not come across.
Neither have I, but somewhere it is mentioned.
Where
And that is why.
See, it gives a good cohort of follicles, number one. Number two,
Absolutely
segmented
correct.
IVF is the mainstay with these PCO patients. So absolutely trigger also, it has become OHSS free with the use of agonist trigger. So
Very.
I mean, I have not come across, even with 30 patients batch IVF, never.
Okay. Let's go back to Dr. Pragya. What is your gonadotropin of choice in a patient with PCO who you are stimulating for IVF?
It is clear that we are going with a low dose, but now problem is that she is very high weight, but still I would like to start with 75.
75, but which gonadotropin? FSH, HMG, FSH only? Okay,
Yeah,
Jyoti,
there
what
are
is your
studies with
gonadotropin of
HMG and
choice?
FSH, they are saying that similar.
I have been using even HMG in the low budget patients. I have not found any difference.
And it works fine for you as
It
well,
works
right?
fine. It works fine.
And what dosage would you start in this lady with a
I don't
BMI of
start with low
34?
dose because for IVF, I mean, there is no reason to worry. You can take out all the follicles, do a good freezing, and then suppress the patient, and it is absolutely OHSS free clinic can be
So
managed.
maximal stimulation and maximal output. That is what Jyoti believes in.
No, I would start as per the age AMH, and I would go with 225, or maybe if the patient is 150 also sometimes. Young
Okay,
patient.
but not 300.
If required, then yes, 300, but I usually start with 150 to 225.
Okay, Dr. Jayan ma'am has raised her hand.
Yes.
Let's hear from our expert.
Yes. First thing is, ASRM 2023 has given guidelines very strongly on patients in whom you expect moderate and severe OHS, how you should go about. ASRM 2023. That is the first answer for metformin, in which metformin has not been taken up. Number two, in all these patients, antagonist protocol is the choice of the protocol. Yes. Even in that antagonist protocol, it is not the fixed one, it is the flexible one. Yes. So then comes the start of your gonadotropin, the dose depends on that particular cycle, AFC, calculated on day 2. Based on that one day, whether you are giving 150, 225 or 300 comes. So this is my opinion up to this stage. I'll come later. Thank you.
Yes, ma'am. We'll have you again later. Yes,
Here,
Dr. Jyoti.
Pratik,
Yeah,
I want to make a point here. When you look for a donor, you're looking for polycystic ovaries. And there you don't use FSH. So where is the double standard then? We always use HMG with all the donors.
It doesn't matter which gonadotropin you use. Even Cochrane says that very clearly. You can use
because all
either
donors are
FSH or you can use
with
it.
HMGs.
That's true that gonadotropins and this all the Cochrane are saying right. But the dose is that madam was saying it's the according to the AFC.
Yes. Yeah, that is true.
I did not say whether you are using FSH or HMJ. I said the gonadotropin dose is based on that particular cycle, AFC. Whatever you use is your experience.
True. Dr.
But
Sugandha,
however,
I'm coming back
if
to
the
you.
LH level on day 2 is high, gonadotropin HMG cannot be used.
True.
Okay.
Dr.
Especially
Sugandha,
in
I'm
a
coming
known
back
case
to
of
you.
PCOS. Okay.
Yes,
please
sir.
go on.
Besides the GnRH antagonist protocol, which all of us are very familiar with today, in a different era when we didn't have the agonist trigger, is there any other protocol that was touted as the best thing since sliced bread, specifically for these patients to prevent OHSS?
Long agonist protocol.
No, not long agonist.
Long agonist, how can we use in
No,
this?
matlab earlier that was used. So
it was used, but
right
there was
now we
something
cannot
better
use
than that as far as OHSS prevention was
because
concerned.
we
Dr.
cannot
Pragya,
give
you want to
agonist
take it?
trigger. Sir, we cannot give agonist trigger in this long agonist protocol. So I would, that is total.
No, I'm
no in this
saying
patient.
before we had the GnRH antagonist protocol, was
Yes.
there any other protocol that was said to be the best protocol for patients who are prone for OHSS, which we don't use anymore, but it's important to convey during the panel?
short protocol was used, I think.
You're close, but it's not short.
Talking about costings,
Has anybody heard of low-dose step-up protocol?
Yes.
Yes,
So
yes,
20
yes.
years back, all of us used to use this when GnRH antagonist protocol did not exist. It was very painful, excruciating, took a very long time, multiple visits to the clinic, too many injections. Patients used to be exhausted. We also used to be exhausted monitoring the patients. but the chances of OHSS with that were said to be less than 5%, and it was very highly appreciated in that era. Of course, today we don't use that anymore because we have the GnRH antagonist protocol. Having said that, if you have a patient who has previously had hyperstimulation, who is going to be an exquisite hyperresponder, the kind of patient who hyperstimulates even with maybe clomiphene citrate, oral ovulogens, in those patients, we are supposed to prefer to use the low-dose step-up protocol than even the GnRH antagonist protocol. So you're using the GnRH antagonist protocol, Dr. Pragya. Can you tell me when do you start your antagonist? What dose for how long?
I start with when the dominant follicle reaches. Like there are two kind of strategies. Patient is far
Reaches
away,
how
then
much?
we use very fix day 6, and then if the patient is able to come for the follicular monitoring, so day 5, 6 we see the follicle. Once it reaches the dominant follicle, the 14 mm size, or its blood supply crosses
So
2/3
is
of the
14,
follicle.
let me stop you there. Is 14 millimeters okay in a patient with PCOS? 14 millimeters is typically said to be the point when you start your GnRH antagonist in general. Dr. Shita?
Yeah, see, there are multiple follicles, so the serum
Correct.
testosterone will be very high. So we have to check for the E2. But if more than
Yes.
20 follicles we see, then I think by 10 or 12 also we can consider giving cetrorelix.
Very good. Sometimes you
Right.
may need to start it a
Can I
little
make a
earlier also
point?
if you have a large cohort
Yes.
of follicles and your estradiol level goes up and triggers your premature LH surge.
Pratik,
Right.
can I add here?
Yeah, of course.
If there are many follicles, as we are talking about this patient, I think, day 5 or day 6 when you are monitoring, with these patients, I would even start, as Sheetal said, 9, 10, the fixed protocol. Day 6 is what is fixed protocol. I wouldn't wait for flexible protocol for it to wait to go to 12, 13 also, because collective E2 would be high to cause any surge. So better
True.
with PCOS, it's a standard policy that you start from day 6
So
itself.
that's another very good approach that especially if you are not there closely monitoring your patient every single day, patients are notorious for
Yes.
not following up,
Sometimes,
being
subjective,
non-compliant.
if there's another person doing the monitoring, sometimes subjective
Yes, that's
measurements
very
also can
important.
be there.
That's very important.
I
So
want to
finally now, yes, go ahead.
I want to add that starting antagonist too early will you will need to increase the dose of
Yes,
gonadotropin.
ma'am, of course. Yes,
So
that's
at the
true.
same time, you have to
But the
increase
chances
the
of
dose.
cancellation would be significantly
Cancellation would
lower.
not be
The
there.
yield of metaphase 2 would be significantly higher, and you want to finish it in one cycle. You don't
In
want
any
that
case, we
headache
are
again.
doing day 5 E2, that itself would also give some indication there.
I
So
too.
now can somebody, yeah, we have just 2 minutes left to go. So I'm going to ask Dr. Sheetal to explain for the benefit of the audience, what is this agonist trigger, agonist trigger, agonist trigger, which we have been shouting from the rooftops. ये क्या होता है, how does it act, and how does it help to prevent OHS?
For prevention of the OHSs, we have started with a very low dose and we have added antagonists, right? So
Yes.
now, when we want to trigger, final phase trigger, like when the follicles are more than 18 millimeter or so we want to give some trigger, but we want to prevent the OHSs. So we don't want to give HCG to this patient. So here we are giving agonist. So
So
that
what is the importance of
works.
avoiding HCG?
HCG is the culprit for resulting to OHSs. So we
Excellent.
don't want to
HCG
give
is the
it.
main reason why you get OHS.
Yeah,
And you have to
right.
avoid
So we
HCG at all
want to
costs.
avoid, yeah, so we want to give LH surge by any means for final phase maturation of the oocyte. So we give the agonist so that agonist goes and works on the pituitary, gives us FSH and LH both surge, and that's how we get maturation to M2 oocytes, right? And then we do retrieve all the eggs. After egg harvesting, we do the freeze all protocol in almost all patients of PCOS.
And we do
because
our segmentation with the
accepted it.
stage transfer. So we've run out of time. I'm going to ask each of our panelists to give one single line take home message to our audience, and then we'll close this panel, starting with Dr. Jyoti Bali.
Aim for an OHSS free clinic. That is the
Fantastic.
bottom line.
Dr. Pragya?
Yes, safer side freeze all if you are doing PCOS patient.
Especially in PCOS. Yes, thank you. Dr. Sugandha?
Prevention of OHSS, it should be analyzed before rather than we go for treatment of OHSS. So prophylaxis is
Correct.
better than treatment.
Correct. So pre-cycle checklist, assessment, ticking all the boxes, ensuring that you have your hormones in place, seeing the patient yourself, single point of contact, constant communication, all of these buzzwords actually need to be put into clinical practice. They should not remain only theoretical concepts on paper. And lastly, Dr. Sheetal.
Yeah, so it should be result oriented mainly and individualized, customized protocols for PCOS patients.
Dr. Jayam Kannan and Dr. Nilamori are experts.
Yeah. There is a recent Cochrane review which says never go beyond 3,500 units of the gonadotropin which you use in any of your patient, whatever be the age. Minimum you can give 1,800, but maximum is 3,500 because the pregnancies have been found to occur only between this maximally. Before that and after that has not been shown to be very clear. Cochrane 2023 review, that picture is very clear. So 10 days of 375 is the maximum which may be permitted. Never 400, never 600 in any patient. As
Thank you,
a
ma'am.
person
Thank you so much.
practicing for the past 40 years.
Thank you, ma'am. Dr. Nilamori, ma'am. You are muted.
PCOS is a very tricky situation. And earlier we know that we have seen many cases with OHSS and we had really restless nights. And now with antagonist and agonist trigger, now we are sleeping at peace. So that is the protocol for PCOS. And it
Thank
should
you
be
very much.
utilized, yeah.
Thank you to all my panelists and my experts. Fantastic panel. Unfortunately, we ran out of time and therefore we could not complete the panel. Thank you very much to all my eminent faculty for the past 3 hours and the past 3 days. The post-test link is going to be posted in the chat box by Shreya and Nilima. You will have 10 minutes exactly for 20 questions, which are MCQs. In case you can't access the link, then this is the QR code which you can scan. At the end of 10 minutes, I will come back and we will discuss the answers. Thank you, everybody.
Thank you.
Thank you, Pratik.
Thank you very much. It was wonderful.
And thank you to the experts.
Thank you, sir.
इसको बंद कर देना यार, भेज दीजिए कारण।
You have 2 minutes left. So time is up. Can I request the backend team to share the answers, please? And then we will go through them. So these are the MCQs for the third day. And today's theme, as you know, was IVF FOGSI and advanced ART. So question 1, which of the following best explains the rationale behind the use of a GnRH agonist trigger in a GnRH antagonist protocol for high responders? A, it enhances endometrial receptivity. B, prolongs the luteal phase. C, induces a physiological LH surge with a reduced OHSS risk. And D, increases the number of metaphase 2 oocytes. Correct answer is C, induces a physiological LH surge with a reduced OHSS risk. This is what we were discussing in the panel as well and was covered earlier. In progesterone primed ovarian stimulation, the primary mechanism for LH surge prevention is via A, direct inhibition of pituitary LH through negative feedback, B, downregulation of GnRH receptors, C, luteal phase suppression, and D, estrogen dominance over progestin action. Correct answer is A, direct inhibition of pituitary LH secretion through negative feedback. Question 3 is which of the following is a potential limitation of using a long GnRH agonist protocol in poor responders? A, insufficient follicular synchronization. B, inadequate suppression of LH surge. C, ovarian cyst formation and profound pituitary suppression. D, increased cycle cancellation rates due to premature ovulation. The correct answer is C, ovarian cyst formation and profound pituitary suppression. Next question, question 4. In dual stimulation or duostim, the rationale for luteal phase stimulation relies on which of the following observations? A, FSH receptors are upregulated in the luteal phase. B, LH levels are highest in the luteal phase. C, antral follicles retain responsiveness post-ovulation. And D, estrogen levels are suppressed, improving response. So the common sense answer there is that antral follicles retain responsiveness post-ovulation, and this is because of the theory of multiple waves of follicles being ready for stimulation. That's what the duostin protocol relies on. Question 5. Which of the following would best justify a freeze-all strategy in a patient undergoing controlled ovarian stimulation? The answers are A, low AMH with normal AFC, B, use of antagonist protocol with GnRH agonist trigger, C, serum estradiol level more than 4,000 picograms on the day of trigger, and D, poor endometrial thickness on day 5. The correct answer is, of course, serum estradiol level more than 4,000 picograms on the day of trigger. Again, this is something which was extensively discussed. ICSI was invented by Gianpiero Palermo in Belgium. That was the correct answer. That's option A. Question 7. FAST and FORT trials are associated with A, male factor infertility, B, poor responders, C, unexplained infertility, and D, stage 4 endometriosis. The correct answer is unexplained infertility, option C. The Hull and Rutherford classification deals with A, adenomyosis, B, tubal factor infertility, C, submucous fibroid classification, and D, histopathology of testicular biopsy. The correct answer is B, tubal factor infertility. Question 9 is something which is again extensively covered earlier. That's EFI, or the endometriosis fertility index. It ranges from 0 to 10. Option A is the correct answer. Question 10. FNPO, or follicle number per ovary, suggestive of PCOS using a transvaginal probe of more than 7.5 megahertz is, the correct answer is C, 20 to 25, as per the new HRA guidelines published in 2023. Question 11. Embryo glue used during embryo transfer primarily contains which substance to aid implantation? I think this was taken by Dr. Shweta during her lecture. The correct answer is B, which is hyaluronate. Question 12. What is the rationale behind using intralipid therapy as an IVF add-on? Option A is enhancing luteal phase support, B, reducing natural killer cell activity, C, promoting follicular development, D, increasing endometrial thickness. The correct answer is B, reducing natural killer cell activity. That's also the way it acts in patients of recurrent miscarriage or recurrent pregnancy losses. Question 13. Mitochondrial transfer techniques in IVF are aimed primarily at A, enhancing sperm quality, B, correcting chromosomal abnormalities, C, improving embryo energy production, and D, increasing uterine receptivity. So that again is a common sense question. Remember, mitochondria are the seat of energy in any cell in the human body. So the obvious answer there is option C, improving embryo energy production. Question 14. What is the main difference between day 3 and day 5 embryo transfers in IVF? Option A is age of embryo at the time of transfer. B, number of embryos that are transferred. C, the technique used to transfer the embryo. And D, the gender of the embryo. Again, this was something which was a very clear-cut message in Venugopal's talk. And the answer is the age of the embryo at the time of the transfer. Question 15. What developmental stage is a day 5 embryo typically in? And the correct answer is option C, blastocyst. Zygote is day 1, cleavage stage is day 2 or 3, morula is day 4, blastocyst is day 5. Question 16. Which of the following is a potential advantage of day 5 embryo transfer? Option A is lower cost of IVF. No. B, higher implantation potential. C, less laboratory equipment needed. No, definitely not. D, earlier pregnancy testing. No, the correct answer is higher implantation potential. And that is why we want to do a blastocyst transfer. Better embryo selection, better chances of clinical pregnancy. Question 17. Why might a clinic choose to perform a day 3 transfer instead of day 5? Option A, patient prefers a longer wait. B, the embryos are more developed. No, of course not. C, fewer embryos are available and may not survive to day 5. And D, it's always the better option regardless of embryo quality. So obviously option D is wrong. B and A are also irrelevant. So the correct answer is C, fewer embryos are available, may not survive to day 5. Question 18. Which statement is generally true regarding success rates of day 5 embryo transfers compared to day 3? Option A is day 3 transfers always have higher success rates. We know that that is not true. B, day 5 transfers have higher success rates due to better embryo selection. We just said that. C, success rates are identical for both, which is false. D, day 5 transfers are only done for older patients. In fact, in older patients, you have less chances of getting a blastocyst. So you would do an earlier transfer. You might do a day 3 transfer itself. So the correct answer is option B. Question 19 is, what do you see in this picture? Very clear-cut picture of a uterine septum, which is an incomplete or a partial septum. And question 20 is, what do you see in this picture? And this is intrauterine synechiae or adhesions. So that takes us through the MCQs on day 3. I'd like to end by expressing my gratitude to the ICOG office bearers, our chairperson, Dr. Parag Biniwale, our our chairperson-elect, Dr. Sheila Mane, our vice chair, Dr. Ashok Kumar, our secretary, Dr. Sarita Bhalerao. Also like to express my gratitude to the ICOG Vice Chair-elect, Dr. Sadhana Gupta, who despite being in transit and traveling, took time out from her schedule and graced us for a few minutes. On record, my gratitude to the ISAR office bearers, our President of ISAR, Dr. Amit Pakki, and our Secretary, Dr. Asha Bakshi. My co-conveners, Dr. Fesilu for day 1, Dr. Seema Pandey for day 2, and myself. Thanks to our coordinators, Dr. Ankita Srivastav on day 1, Dr. Anu Agarwal on day 2, Dr. Monica Singh, who has been here since before the program started and is here all the way till the end. For today, thank you very much. And the two masters of ceremonies, Dr. Varda Aroda, who was there yesterday, and Dr. Aarti, who is here today. Dr. Monica, closing remarks from you, and then we'll call it a day.
Thank you very much, Dr. Pratik. One very agonized candidate just called me up who happens to belong to Bhopal. She
Okay.
had appeared for day 1 and day 2 test, but this test she could not submit on time. So,
Oh my God.
so I think it's like nothing can be done, no?
I think she'll need to speak to the ICOG office because I've already
Yeah.
given out the answers now.
So I will tell her to mail the office for the
Yeah.
same. And coming to the end of this wonderful, wonderful session, and I have been a part of ICOG certificate courses. I myself have appeared for 3 courses and taken the certification. I assure all candidates that this is all the, wonderful learning which you could get in a compact form in very thoughtfully designed capsules over a period of 3 hours. In 9 hours, you have completed almost all of your infertility textbook with lots of evidence, great speakers, and wonderful convenership by Dr. Pratik Tambe. And definitely ICOG, FOGSI, and ISAR are going hand in hand to take academics forward in a way which is totally, totally wonderful. Thank you so much for the opportunity, Pratik.
Thank you very much, Dr. Monica. Wishing you and Dr. Aarti, thank you very much, despite your busy travel schedule, joining us from various different places, from the back seat of a car, from the front seat of a car, from the clinic, etc. Thank you for being here. Thank you for all your hard work behind the scenes. The next ICOG certificate course will be on Wednesday, Thursday, and Friday of May. And the dates, if I can just look them up, are 28th, 29th, and 30th of May. So those will be announced very soon in the next couple of weeks. This particular course, all the presentations will be there. The recorded videos will be there on the ICOG website in a few days' time. So look out for those. And the certificate, of course, will be mailed to all the participants who've scored more than 50% on all 3 days. You need not put your email address in the chat box because at the time of registration, your email address and your phone number have already been captured. Thank you very much, everybody who logged in over all the 3 days, and we look forward to seeing you in the next ICOG certificate course. Until next time, goodbye, God bless. Thank you very much, backend team. Nilima, Poonam, Shreya, thanks a lot for being there.
Thank you, sir.
Thank you.
Thank
Bye.
you. Thank you.